those topics are normally not discussed in depth. So I thought that those topics will bring in and discuss with the audience and other panelists. During this time of 25 years, we have achieved some. We are affiliated to our parent body, All India Ophthalmological Society. Every year, All India Ophthalmological Society gives us a slot to have the trauma session by the Ocular Trauma Society of India. I will give you a news that this year, 2020, we are entrusted to conduct National Symposium of Ocular Trauma during the conference of All India Ophthalmological Society at Gurugram. And this society was started in the early part of 1990 on the advice of Dr. B. Shukla, Professor B. Shukla, and Air Marshal Dr. Boparai, along with, these are the two living legends I am telling you, and along with other people supported were Professor Harimohan and Dr. Satish Sabarmal. We are few of the members. We also took part at that time. In the initial phase, we used to have triennial meeting. Now we are having every year meeting. That's a great achievement. That means we have so much of material. We have so much of material with our members that we can conduct a full day symposium or a seminar with the Ocular Trauma Society of India. Besides that, I will tell you that during these 25 years, we have organized 2 world congresses. The last World Congress was in the month of December 2019. And this was possible because of the interest of the members and other ophthalmologists in the trauma. In order to create more awareness, trauma as a subspecialty, what we did, that we went to most of the states of India and we conducted a session in the state to create awareness that trauma is there and trauma will be there, and we must have a trauma session on each and every ophthalmic conferences. Now, along with this, we got a lot of support from our past president, past secretaries, who has built up to this extent that we can vouch that we are in a platform with any international society as we have today. With this, I'll tell you that today's symposium is something different. There's a video symposium, and the most credit goes to Professor Natarajan, who actually instigated me and Mehul to conduct this type of video conferences. I don't think you will be disappointed by observing this one, because we have international faculty of well reputed and national faculties who are well known throughout the world. Thank you very much for kind attention. Thank you.
And thank you.
Now I will request Professor Natarajan to introduce our international guest faculties in detail, and then they will be called one by one for the presentation.
Thank you, Dr. Mukherjee, for the opportunity, and I'm happy as the past president of Ocular Trauma Society of India, welcoming all the speakers and the panelists and the doctors who are watching this interesting video session. And can I have the next slide, Sai? We have 4 speakers like Dr. Robert Redak from Poland, Dr. Zoran Tomek from Belgrade, Serbia, and Uppsala, Sweden. Then we have Dr. Matthew Forlini from Italy, and we have Dr. Hudson Nakamura from Brazil, which when they start, I'll ask Dr. Mukherjee to mention about the Indian speakers now.
Thank you, Natarajan. Our national faculties are Dr. Natarajan. If I say something about Dr. Natarajan, whole of this symposium will be covered. So just I'll tell you that he is a very dynamic person, and he is really active. Whenever he takes some job, he shows that it is done. and from him we get a lot of support for the ocular trauma societies. He has a lot of interesting papers. He has a lot of publications. He got a lot of awards. You can name any award possibly. He has got those. He was our past president of All India Ophthalmological Society. He already told, and other societies also. But I just mention one thing, that he got civilian award as Padam Shri, which is one of the big achievement in his career. Another important achievement in his career is that he got the national recognition for working in the Jammu Kashmir area during this war time. That is a very great achievement. Hardly anybody gets that type of achievement. So this is Dr. Natarajan, and detail will be told to him, told to you by other Dr. Mehul sir. Our second speaker from national second faculty is Dr. Ashok Grover. If I say something about the Ashok Grover, it will also be very little. He is also a dynamic person. He is the past president of All India Ophthalmological Society and other societies also. He is vice president of the Ocular Trauma Society of India, and he has a lot of work on the oculoplasty and the trauma. He is going to present some of this work today, and he has won a lot of awards and lot of recognition and orations throughout the world. Our third presenter from the national side is Dr. Purender Hasin. He is from Gwalior. He is also a very dynamic, active person, very good surgeon, and has got good organizational capacity. He was earlier the secretary of the Ocular Trauma Society of India. Presently, he is vice president of Ocular Trauma Society of India. He is also, he received a lot of awards, and possibly he is going to show us one of such, which he got about 2 years back from All India Institute of All India Ophthalmological Society, that award for his presentation. These are all national faculties. In these details will be told by our secretary, Dr. Mehul Shah. Now I will request Dr. Mehul Shah to call the speakers, these presenters.
So Dr. Robert Redak is a great friend and a professor of ophthalmology, president of the Polish Society of Ophthalmic Surgeons, and chairman of the Department of General Ophthalmology at the Medical University of Lublin. And I just heard from him that he's going to become the vice rector of the university. He's also a faculty member of ISASU and vice editor of the Ophthalmology Journal. So with this, Dr. Mehul, you can invite Dr. Robert Redak.
Thank you very much, Professor Natarajan.
Mehul?
Hello, do you hear me? Can I start? So
yes, you can start.
Okay, I am very honored to be invited today to present you my experience in ocular trauma. Today, I would like to focus on foreign body extraction. There are different situations, clinical conditions. So sometimes you really should decide during the surgery about the strategy. So this first case is a young man, 24 years old, with foreign body on the macula region, but we have the wound in the cornea, in the lens, and metallic foreign body in posterior paw. So I could remove crystalline lens using vitreous cutter, avoiding hydrodissection, and to implant into capsular bag IOL. Then I continue with 25 gauge vitrectomy. We identified intraocular foreign body, but this is the young patient, so we performed really broad core vitrectomy, and now we create additional sclerotomy with chandelier light to remove gently foreign body using bimanual technique. We inject perfluorodecaline to protect macula against additional injury, and having 20 gauge forceps and assisting with the left hand with 25 gauge forceps, we gently remove foreign body, even for a while stopping the infusion. We close the sclerotomy, and of course we continue with vitrectomy. Now we want to perform complete vitrectomy with PVD. This is a young patient, so it is not really so easy to initiate PVD. Normally I use the technique with a needle to initiate PVD, to start gently, avoiding pulling hyaloid with needle. Then I continue with vitreous cutter. We perform complete vitrectomy, avoiding, of course, additional injury to the retina. We check also the wound. There was a wound in the retina. So after careful inspection of the periphery and shaving vitreous base, we perform laser retinopexy around the retinal wound. And in this case, gas tamponade was used at the end, just to avoid retinal detachment. I preferred to leave SF6, 20% concentration of SF6. The result was really good, functional result in this case. Okay, let's continue with another case. So this is nightmare in my career. 6 years old girl sent from another center with the part of inhalator. This is plastic band with the metallic ending. So the story was not really clear. I discussed with parents, with the referring doctor. They told that the girl has a plastic band in the eye, and in a previous center they couldn't remove it. So we of course checked the other part of this plastic band, also performed ultrasound, but it was not easy to diagnose the situation. So during the surgery, with a group of my friends, we discussed, of course, I couldn't just pull this plastic band. So I decided to somehow find the position of a metallic part, and I created T-shaped sclerotomy at the end of the metallic part. So then I could avoid additional damage and removed this metallic foreign body in this way. This was really a fortunate situation, because after closing T-shaped sclerotomy, of course, we should clean remnants of vitreous body, not to incarcerate vitreous into the wound. So first we close T-shaped sclerotomy. Then we discussed what to do with anterior segment, because it was really a big wound, corneal wound. I removed lens material from using anterior approach. I used some visco to look under the iris, and but because of the scar, so now we closed the wound, corneal wound. There was a big scar, bad visibility. So I decided to stop at this point. And it was a really good decision because afterwards, follow-up showed that there was no retinal detachment. We could, after like 8 months, implant IOL. The girl could attend the school, so we rescued the eyeball. Next step is the decision, what about cornea transplantation. Of course, the result is not, let's say, ideal, but it's finger scanting from a couple of meters at the moment. But we could save the eye globe, no retinal detachment, and we will continue follow-up, planning carefully next steps. Next video, please. And this case is also quite interesting. Young man sent from another department. Doctors couldn't remove metallic foreign body, and trying several times, like 3 times, they entered anterior chamber and they pushed metallic foreign body to the angle, probably not having forceps, and it was totally hidden in the. So now you see, after cataract surgery, we could make angle wider, also with dense visco, and using gonio lens, we could identify the location of metallic foreign body. Anyhow, there were signs of siderosis. So this patient was treated for several months until, so to say, the situation was really stable. Next video, please. This is another foreign body, again, corneal wound and post-traumatic cataract, but because of big size of metallic foreign body, the lens was, of course, ruptured. But again, I'm using vitreous cutter to avoid pulling vitreous and to avoid inducing retinal breaks. Then we find already the intraocular foreign body with some retinal necrosis in the area of the macula. So using bimanual technique, we enlarge the corneal tunnel, and we try. So it was aluminium. This metal was aluminium. Was not ferromagnetic. So this was the best way to remove it. And also we checked posterior pole. We continued with vitrectomy, so PVD. Also because of the wound and the area of necrosis, I decided to perform ILM peeling to prevent PVR in this region afterwards. And at the end, after so some laser and checking periphery of the retina, of course, performing also vitreous base shaving, we decided to implant the lens IOL into the sulcus, 3-piece lens, and we used silicone oil to prevent endophthalmitis because there was vitritis already, and also visibility of the retina was not so perfect, so I couldn't exclude additional retinal breaks, so we decided to instill silicone oil. Next slide, please. So this is special case with really giant metallic foreign body perforating through posterior pole. So really hemophthalmus was not easy to detect details using ultrasound. So we performed phacoemulsification. The case was done by my colleague Professor Katarzyna Nowomiejska from my department. So, as you can see, this giant metallic foreign body perforated through posterior pole, and there was a risk that through this wound in posterior pole, we will lose fluid, there will be hypotony after removal of a metallic foreign body. So we decided first to perform a complete vitrectomy with PVD, with laser retinopexy, then to instill silicone oil and to remove this metallic foreign body under silicone oil to protect against expulsive hemorrhage, against hypotony. And in my opinion, it was a good strategy because of some observations in previous cases. When you have a perforation through the posterior pole, there is a risk of sudden hypotony and expulsive hemorrhage if you do not have silicone oil tampon. Thank you very much for your attention.
Robert, I think as usual, wonderful, and the panelists, Dr. Ravi and Kim and others can start the discussion.
Please.
Those are amazing cases to
Robert,
see.
I have a little clarification. How could you assess that in the case of that plastic thing along with the plastic body inside the eye, how you could ascertain the size of that particle that is intraocular?
Thank you very much. So fortunately, I had second part of this plastic band. It was exactly the same. So we measured the size. We could also imagine somehow how it is located, but at the moment still we do not know how it could happen in such a small eyeball of 6 years old girl, but it went through the cornea and opened with harpooning effect under the eyes. But again, having the second part exactly the same size, the same so to say conditions, we could imagine the location and the position of this part. It was the most difficult part in this surgery, in fact.
I have a question to Dr. Dr.
Yes,
Robert, very nice presentation. All the cases are amazing. I just want to know the last case, that is the case number 5. You have shown a perforation of the posterior pole. So have you ruled out any orbital foreign body, or have you done any image to rule out any orbital foreign body? Because it was a metallic foreign body with a perforation in the posterior pole.
Yes. So we had CT scans. We knew exactly what is going on. So from my experience, I had such cases that when I even moved such foreign body, then sudden hypotony happened, or hemorrhage, expulsive hemorrhage. So since years, I recommend my young colleagues, so it was my coworker performing the surgery, to use silicone oil. So in this case, silicone oil was left, but sometimes you can remove it and continue surgery depending on the critical conditions, because of bleeding, bad visibility, and so on. So it might the scenario can be different. But of course, thank you very much for really good question. You depend on your imaging, pre-op examination to have the let's say better knowledge about the situation.
Thank you, Dr. Robert.
Excuse me, there is a question from Dr. Sanjeev Mohan in our audience. Why the AC was not formed in second case?
Sorry, again.
Why the anterior chamber was not formed in second case? This is what he has asked.
Why the anterior chamber?
Anterior chamber.
There was no air injection in anterior chamber.
No, sorry. A good question. But I gave Visco in this case. First of all, at first step, I gave Visco to create the space, also to protect iris, to protect endothelium. Then during the repair, we left some Visco, so air would be also very good option. I really agree at the end of the surgery, but in this case, Visco was really good option too. There was no inflammation, no problem afterwards.
I have clarification for this, that if you put air in a hypotonic eye, there is a tendency of going to air into the posterior segment. That's the problem, rather than leaving as such as you left it.
So you really, in such cases, a young child, risk of expulsive hemorrhage, many factors. Additional maneuver also might be harmful. So that is why I did as less as possible. And so I have entire documentation of this case. So it was really successful.
And Dr. Kim wants to ask something. Yeah. Kim has a comment.
Thank you, Dr. Robert. Thank you for those excellent videos. I just wanted to ask you, do you routinely feel the ILM in all your trauma cases, or is it?
So I learned in this moment, I would like to remind my great friend and teacher, Dr. Cesare Forlini, and also special thanks to Professor Dattarajan, my teachers. They taught me to remove ILM when there is a wound in posterior pole nearby macula as a prevention of secondary Packer or PVR. So if I have the wound, I have bleeding, I have contact with subretinal space nearby the macula, then I decide to peel ILM.
Oh, thank you.
I think, yeah, that's only to avoid proliferation, and I agree with Rob.
I have a quick question, a very quick question. Please, Dr. Rijak, and your surgeries were so beautiful. The case is complicated, and I don't usually like doing the vitrectomy and injecting the triamcinolone to see the vitreous. I'm comfortable doing without using triamcinolone. You always use triamcinolone to see better the vitreous in all your cases, or only some?
Oh, I am a fan of triamcinolone. So I was my education started in an era of triamcinolone, and I only can congratulate you that you are able to do all you want without triamcinolone, because in my hands I feel safer. I am also pharmacologist. I did many studies on vital dyes, also with German colleagues. So at the end, I try to remove all triamcinolone from the eye globe, not to leave really white spots, but especially in young patients, when hyaloid is very attached to the macula, it helps me. In trauma, additionally, quite often I have poor visibility due to corneal wound, opacification. So also triamcinolone is helpful, in my opinion. Might be helpful.
Thank you, Robert. Now I request our next presenter, Dr. Ashok Grover, to present the cancer injury. Dr. Ashok Grover is the founder chairman of the Vision Eye Center, New Delhi. He was alumni of the Rajendra Prasad Center for Ophthalmic Sciences. He is also chairman of Ophthalmic Department of Sir Gangaram Hospital in Delhi. He was past president of All India Ophthalmological Society. He received Padma Shri Award from the Government of India for his excellent work in the field of ophthalmology. And he is also a good evaluator for the undergraduate and postgraduate studies. And he has done a lot of work on this. I request Dr. Ashok Grover. Before that, Dr. Mehul Shah is going to invite Dr. Grover for his presentation.
Yeah, good evening, Grover. Good evening, Dr. Grover. Please, you may start your presentation.
Okay, we may start the video now. The canthal trauma is one of the most difficult areas to handle. The injuries are important because unless handled well, they lead to some of the worst deformities that we can see. So how do we tackle these canthal injuries? Lateral canthal disinsertion from the lateral rim is one of the commoner problems. It is important in these cases to cause a good attachment from the lateral part of the tarsus to lateral orbital rim. And this is done with the help of double arm sutures using a material like Prolene, which is permanent. It is important in this attachment to make sure that it is done exactly in the right position at the Retinal's ligament, that the bite starts from behind the orbital rim in the periorbita and then comes anteriorly. In the medial canthal trauma, what is important is the integrity of the posterior crus of the medial canthal tendon. And that is what has been broken in this case. There is an associated canalicular trauma, which we will be speaking about later. Here again, we are trying to align the medial posterior crus of the medial canthus with permanent Prolene suture. In other cases, we may need to anchor the medial canthal tendon to the posterior crust. Associated canalicular injuries are required to be managed well in the medial canthal trauma, and it is important to identify the medial cut end. Here we are using an improvised material from the intracath available in our OT. Once the pericanalicular sutures have been placed, margin is aligned and anchoring sutures are given to the tube to ensure that it stays in position for the desired period of at least 6 weeks. If primary trauma is not managed well, you end up with bad deformities like you see here. This is a downward displacement of the lateral canthus, which is quite severe. Here we had to open up all the attachments, re-anchor the lateral canthus at the proper position, but also had to do a posterior lamellar hard palate graft, and we could reposition the lateral canthus. Medial canthus may also show telecanthus as well as a downward displacement. Here, the downward displacement has been tackled with a Z-plasty, where the lower limb is being transferred upward, and with all the removal of adhesions and attachments and scar tissue, you can get a correction. Here, there is, in addition to the traumatic telecanthus, a big scar and a misaligned eyebrow. After a revision of scar, the brow was realigned and medial canthus anchored in position to give us this result. The canthal deformities may be associated with NOE fractures or naso-orbitoethmoid fractures with bad scars. So we need to remove all the bony scar, and to re-anchor, sometimes have to put in a bone graft like this to do a nasal wiring, revise the scar, and you are able to improve the position significantly. But these trauma cases are difficult. Now, this is again a bilateral NOE fracture sequela. We had to work with a bicoronal flap, realign the bone, and do a transnasal wiring along with a bilateral dacrocystorhinostomy. But many cases, the low profile mini plates are the best choice. And we use small 2 to 4 hole plates with very short screws drilled superficially to avoid any trauma. This is an example where a Z-plasty has been done. Medial canthal region has been exposed, and then the bony area, bony deformities, and the scars are corrected. A mini plate was then put in, and the medial palpebral ligament anchored in position to get a good correction. Canthal trauma can be difficult to handle, but the results can be extremely gratifying. Thank you.
Gangadhar?
Yeah. Thank you, Dr. Grover. That was excellent exposition of the talent which is required to get it right. And one of the principles we talk about, like in a lot of other vitreoretinal surgeries, is getting it right the first time. And you don't get a second chance to get it right the first time. So that's a driving principle Dr. Grover is trying to share. As he beautifully showcased, the medial canthus is very different from the lateral canthus, as excellent vital structures. And we should not forget the fact that it's very close to the skull base. The skull base is only a few millimeters superior to the medial canthal tendon, which we are all familiar with. He also beautifully highlighted the value of not just the anterior limb of the medial canthal tendon, which is anterior to the lacrimal sac, but the posterior limb or the posterior crux of the canthal tendon. That's what gives us the posterior direction of the medial eyelid. We have to remember there's yet another crux of the medial canthal tendon, that's the superior crux. So getting the eyelid, the medial canthus, not just medially, not just posteriorly, but superiorly is also very important. Otherwise, the whole thing gets dragged down itself. I think he also showcased where when you see in association with naso-orbitoethmoidal fractures, where sometimes even the medial wall of the orbit is involved or the lacrimal sac is also involved, you can either prophylactically intubate, or when you do a revision procedures, you may have to do a dacrocystorhinostomy. And the traditional mindset of ophthalmologists is DCR is a dirty procedure. That's not how we oculoplastic surgeons see it. We think it's a very clean procedure if you do it right, unless you're dealing with an acute or chronic dacryocystitis. And he highlighted the value of working with craniomaxillofacial teams, because when you raise a coronal approach, getting that access to the posterior limb or the medial canthal tendon, getting access to the root of the nose, because sometimes you end up combining with a rhinoplasty, you end up building the nasal bridge, is also very important. Like a lot of other situations, a congenital ptosis, for example, that we do, or a cicatricial entropion, even if you do your best job, a lot of times we end up with an undercorrection. So thinking in mind that you are going to get an undercorrection, we try to overcorrect, secure the canalicus and the lacrimal sac, and doing it at the right time with nice exposure. And nowadays we can do a lot of these procedures with small incision approaches. It goes a long way so that you don't have to deal with these deformities in a later stage. I'll invite Dr. Kasturi to make a few comments.
It was an excellent presentation. All the cases has been shown so well, managed very methodically. I don't have anything much to say, just I want to add 2 points. Grover sir has shown very nicely the management of lateral canthal dystopia, and the Prolene suture, that is the suture that many of us are using, but I want to share my experiences, like those cases which I had done around 7 to 8 years back. Sometimes I find the cheese wiring of the Prolene suture, and this leads to a recurrence of the dystopia. So at present, from a Prolene, I have switched up to the Polydec, that is the Polydec suture. And secondly, sometimes it becomes a little difficult to identify the medial end of a canalicular injury. So there are different ways of identifying. But the best way is that if you can inject air or a viscoelastic stain with fluorescence, so that once it comes out from the other end, you can visualize the proximal end. But in spite of doing so much also, sometimes it is more difficult. Then in that situation, what we do, we just put a little amount of phenylephrine so that it is a vasoconstriction, and then we can see the opening. So these are just some of the points that I like to add to it.
Thank you. Excellent observations by both very experienced oculoplastic surgeons, both eminently qualified to speak on the subject with the abundance of experience. We have a wonderful book on fractures by Dr. Gangadhar Sundar, which we learn a great deal from. And it's really nice to have their comments.
Great. So, Sai, next video.
Yeah, you call next figure.
Yeah. So we have Dr. Matthew Forlini, and he's not new to India. And I'm happy he was a fellow at Aditya Jyoth. His father was a visiting surgeon at Aditya Jyoth in Mumbai. And I have operated in his father's place. And I also went to his place in Parma in Italy, where the cheese is very famous. And I don't like cheese, but I like Matthew. And I love Matthew and his family. And regards to him, thanks for Matthew for joining us. And he's a great anterior segment and a posterior segment surgeon, and representing his dad, who's very close to all of us, Cesare Forlini. He's a pole-to-pole surgeon. And Matthew, off to you.
Hello, thank you again for invitation. It's really a pleasure to be here with you. And I can show you the first video. I show you some cases, very difficult. This special case, you can see after severe ocular trauma, the cornea is very bad, very cloudy for corneal scars and corneal wounds for previous surgery. So this is to show you that even if you have a cloudy cornea with corneal scars, you can do vitrectomy without corneal transplantation. So you can avoid corneal transplantation sometimes if you use a wide angle viewing system like Biome, I'm using Biome in this case, and chandelier lights illumination. This is total retinal detachment, you can see. And I'm injecting PFCL to flatten the retina. You can see the vision is not so bad, even if the cornea is very bad. So the vision can be better than you expected. After flattening the retina using PFCL, I'm staining with triamcinolone. I'm also a huge fan of triamcinolone, like Dr. Robert Redak said before. I say big hello to Robert, and I totally agree with Robert because triamcinolone can help us a lot. This case was a recurrent retinal detachment, so the patient was already vitrectomized. So I'm just trying to remove the vitreous remnants from the previous surgery, and I just found the retinal break. There is a retinal tear at 9 o'clock in temporal sector. Now I'm removing PFCL from posterior pole because I want to inject the blue staining, the dual blue staining, to stain the ILM in the posterior pole to treat the macula hole, because also there is a full thickness macula hole. This is glucose gel. Glucose gel on the cornea can help us for the visualization. So after blue staining, I inject again PFCL. So I'm doing ILM peeling with Thanos scraper and Eckert forceps. I'm using a 23 gauge instrumentation, and you can see I managed to perform ILM peeling under PFCL, even through a bad cornea, even through a cloudy cornea. So sometimes the cornea scar is not so difficult for the visualization. So after ILM peeling, you can see very clearly the ILM peeled area. So again, I'm injecting triamcinolone to complete the peripheral vitrectomy, checking for the vitreous base and trying to clean all the base of the vitreous. And then finally, I perform endolaser in the retinal tear, of course, but also all over for 360 degrees in the periphery. I always do 360 degrees endolaser in these severe ocular trauma cases. And then final PFCL air exchange. And then I'm just to prepare for the indirect exchange for the final tamponade with oil, silicone oil, 5,000 centistokes. I chose in this case the silicone oil 5000 centistokes because this was a reoperation. As I told you before, this was a recurrent retinal detachment after many previous surgeries. So final tamponade with the 5000 centistokes because this oil can last for many, many years or maybe forever. And this is the final check of anterior segment because there was some synechiae between iris and corneal endothelium. So I removed the iridocorneal synechiae, and this is the final result. The retina is totally reattached and tamponade with the silicone oil 5000 centistokes. And this patient was young, was 25 years old. So after many operations, I hope that this is the last operation using silicone oil 5000 centistokes for many years, maybe forever. So second video. This is another case. Again, ocular trauma with severe corneal injury. But you can see now this corneal injury is much worse. So it's mandatory for PK. So I have to remove, in this case, I have to remove the cornea because the cornea is destroyed, is too much damaged. So I cannot see through this cornea. So I remove the cornea and I'm preparing for the positioning of TKP, for the temporary keratoprosthesis by Eckert. So this is the temporary keratoprosthesis and this is the positioning using the suture. Usually I use a Vicryl 80 for the suture, and this is the retina. You can see there is a good news because the retina is not detached. So this patient was lucky. The retina is still attached. But I'm doing vitrectomy, of course, and I'm preparing to remove, you see the crystalline lens. The crystalline lens was completely luxated in the vitreous chamber. And before removal of the crystalline lens, of course, I have to remove all the vitreous surrounding the crystalline lens. And then with the 23 gauge vitrectom, I'm trying to remove the lens. This crystalline lens was not hard because this patient was young, was 40 years old. So it was not a dense cataract, it was just a traumatic cataract. So the lens was soft. And then I'm checking the periphery of the vitreous and you see, just checking all the vitreous base because we always say that in this case of severe ocular trauma, it's very important to check all the periphery and you have to obtain a very, very complete vitrectomy with vitreous base shaving. You have to remove all the vitreous remnants, even in the extreme periphery. So this is very important to prevent retinal detachment. So I am also removing blood clots in the vitreous chamber, and you can see little by little I'm performing all the vitreous removal, even in the extreme periphery. But fortunately, the retina still remains attached, no retinal breaks. And this is the final endolaser, again, for 360 degrees in our periphery. I always do endolaser for 360 degrees in such cases like that. And then at the end, I remove the temporary keratoprosthesis and I'm positioning the corneal graft to complete the perforating keratoplasty. So this is the classic perforating keratoplasty technique. I prefer using the separate corneal stitches, as you can see, nylon 10-0, of course. And this is the final result. The retina is attached, and this is the final exchange PF with the air, because I preferred to tamponade with air. Again, next video. This is the same patient. So the same patient, 4 months later, the patient asked for artificial iris implant because, of course, the patient remained aphakic and anuridic. So the patient asked me to correct aphakia and anuridia. So I ordered the artificial iris prosthesis, and this is a classic scleral fixation with the 3 scleral pockets at 12 o'clock, 4 o'clock, and 8 o'clock. This is the artificial iris prosthesis by Rapper. Rapper is a Russian company, and this prosthesis is very nice because you can choose a lot of colors. You have more than 300 of colors available, so you can choose the exact color for that patient, and the IOL is included, so you also can calculate the eye power. In this case, it was 4 months after the corneal transplantation, so I just removed the previous corneal surgery, so I prefer to reopen the corneal wound of the corneal transplantation, and I just insert the artificial iris prosthesis. You can see the prosthesis is foldable because it's silicone made, and I prefer to suture first the 4 o'clock and 8 o'clock position, and at the end I suture the 12 o'clock position. So I'm using Prolene 10-0, like in the classic scleral fixation technique, and then finally I suture again the corneal opening in the same line of the previous corneal transplantation. And then you have to check the positioning because of course it's very crucial to obtain a perfect centration of the pupil. And when you get the centration of the pupil, you just close the 3 suture, you close the scleral pocket, and you close the conjunctiva. So this is the end of the operation, and the last final result is good. The patient is happy because now there is a crystalline lens, there is iris, the retina is good. So the patient was very satisfied for the result. So next video, last video. So this is my last case. Severe ocular trauma after bottle cork. So this was a closed globe trauma after bottle cork injury. You can see vitreous hemorrhage, iridodialysis, and this is the lens. The crystalline lens was completely luxated in the vitreous chamber on the posterior pole. You can see the iridodialysis is very big, and I'm performing, of course, vitrectomy, the peripheral vitrectomy, again, the same concepts. I'm using triamcinolone to stain better the vitreous, and I found a big retinal tear. So this patient was lucky because I found a big retinal tear, almost for 180 degrees, all the inferior part of the retina. So it was like a long retinal tear, circumferential, from 9 o'clock to 3 o'clock in all the inferior sector of the retina, but no retinal detachment. So the patient was lucky because the retina was not detached, even if with a big retinal tear like that. So I immediately closed the retinal tear with endolaser, of course, and I completed the peripheral vitrectomy with vitreous base shaving. And then now, finally, I deal with the crystalline lens. I inject some perfluorocarbon, some PFCl on the posterior pole to protect the macula during this procedure of crystalline lens removal. This patient was young, was 35 years old, so the crystalline lens was soft, as you can see. It was not a cataract, it was just a crystalline lens dropped in the vitreous chamber, so it was very easy to remove the lens using the vitreous catcher. And then final endolaser for 360 degrees in periphery, and of course in the retinal tear. And then I'm managing the anterior segment. You can see there was a huge mydriasis. I'm removing some blood clots from the angle. So there was a lot of, you can see, a lot of blood clots in the angle. And then I'm implanting iris claw IOL in the posterior surface of the iris. So this is the retropupillary technique, and enclavation in the posterior surface of the iris. And I'm just pushing the iris tissue back in the anterior chamber because there was, as I told you before, a big iridodialysis. I'm closing the cornea. Usually I have to open the cornea 5.5 millimeters for the iris claw implantation. And then this is the Sipser iris technique, because this is the sliding note technique by Sipser, and it's very useful, the Sipser technique, to correct the iris defect for iridoplastic technique. So with the Sipser I'm using Prolene 10-0 suture, and I'm creating this sliding knot, the slip knot technique. And when I pull the sliding knot, you can see that the suture goes inside the anterior chamber, and I can close the iris defect. And of course, at the end, I cut the suture. And so in this way, you can obtain a better pupil. Then final exchange with the air and then with gas. So even if the retina was attached, I prefer to tamponade with gas, C3F8, because you never know. So this is the final result. The lens is stable, the pupil is good, and the happy patient was satisfied. So thank you again for the attention and for your kind invitation.
Wonderful, Matthew. I'm proud. I also wanted to say that Matthew had accepted one of our fellows. She is now a consultant retinal surgeon in Mumbai. I don't know whether she's participating, Dr. Purva, and they both have published together. I'm happy we are also publishing along with Matthew as well as Robert in the Ophthalmology Journal. So now I expect Dr. Kim and others to start the discussion. Wonderful. I'm very happy to see you. You're an excellent, wonderful surgeon. I'm seeing probably something like 30 years back as a school kid, and I'm seeing a great surgeon now.
I always Professor Natarajan, because I never forget my period when I did my FACO training in your clinic many years ago. So really, you are one of my mentors.
Ravi, you have any comments? Ravi? Kim.
Dr. Kim.
Can I have a question?
Yes.
In the second last case that you have shown with the artificial iris, so any chance of developing postoperative glaucoma, and if so, how you have managed?
Okay, you mean after artificial iris implantation? Yeah. Yes, actually, I had some ocular pressure raising after that, but I could manage that only using topical drops, so only with drops, and I didn't need to do surgery for the IOP increased. Actually, I have to say that this artificial iris prosthesis, as you saw, the design has 3 small loop, very, very small, and the rest of the artificial iris is smaller than the white-to-white. So you have space all around. So in this way, there is a space for the aqueous, for the humor aqueous to flow. And usually, in my experience, I did 7 cases with this artificial iris prosthesis. I never had to do surgery for secondary glaucoma, but usually drops 1 or 2 different medications, topical drops. Yes.
Dr. Forlini, amazing cases. Quick question on your third case. When do you consider an iris claw IOL? When would you consider a Yamane technique? What's your go-to in those situations, please?
Oh, yeah. Okay. Very good question. Yamane technique is fantastic, but I suggest Yamane technique only when you already have a 3-piece IOL inside the eye. That means that, for example, you can have a 3 pieces IOL subluxated or decentrated or luxated in the vitreous chamber. So in this case, you already have a lens in the eye, so you can use that lens with the Yamane technique. But if you have a aphakia, if you have a complete aphakia for some reason, so you can choose whatever lens. In my experience, I prefer iris claw. Because I prefer it as I think it's faster technique. In my experience, I'm more confident, and I think usually it gives me more percentage of success. Because Yamane technique, sometimes I'm worried about the centration, or maybe can one loop can be luxated. I don't know. It's my opinion. I also want to underline Carlevale lens for scleral fixation. I don't know if you know that, but in Europe it's very popular. So it's a foldable one-piece lens for the scleral fixation without suture. So it's sutureless scleral fixation, one piece, foldable. So I think it's another very good option.
Thank you.
Dr. Matteo Forlini,
Yeah.
you were, I'll have to say, you were bravo. Very good surgery, you know.
Thank you.
Very good.
Thank you very much.
I just want to make 2 comments. For the first case, the media was quite hazy, but you could get away with that and do a very good vitrectomy, and also with the tendon scraper and ILM through the cloudy cornea. And what lens did you use for seeing a good, having a good view from the ILM?
What nest? What you said?
What the lens? What the macular lens you use?
Oh,
Viewing system.
The angle, the wide angle viewing system, Biome. You know Biome?
Yeah, I know Biome. Yeah.
So
I prefer.
I use the Biome. Yes.
I prefer the contact systems.
Also,
but, the lens you used. Did you use the macular lens for the Volt system?
Yes. Usually at the beginning of the case with Biome, I'm using the wide angle visualization, the panoramic lens. Then for the macula island peeling, I changed the lens and I put the 90 diopters, the macula Biome lens. No contact.
Okay.
And after I finished island peeling, I go back to the panoramic view again. Okay.
I will switch to the panoramic.
Yeah, but I agree with you. Also, the contact lens, the flat contact lens on the cornea is very good. So usually I use that as a second choice. If I cannot see good, I put the contact lens. Of course, with the contact lens, you have a smaller field. You have a big magnification, huge magnification with smaller field. So that's why I think there are pros and cons with both of these.
Okay.
Hudson, I'm happy that Matthew is using the same Biome. Because me and Cesare introduced Biome in 90, immediately after Spitzner's published it. But I think I remember Dr. Di Juan coming and saying, "Oh, what is the use of Biome?" But I remember 96 in the vitreous surgery meeting in Vitreous Society meeting in Italy. I think he did a live surgery from Johns Hopkins. He was in Johns Hopkins, and he said, "I love Biome." So I want Kim to comment. And I remember when I introduced 90, I think it took almost 10 years for India to take up Biome. And so Dr. Kim to comment on Matthew's.
Thank you, Dr. Forlini. Those are excellent videos. I think like father, like son. Beautiful videos and good cases. I just had a few comments. One was that in the first case that you showed, you removed the PFCL to stain the ILM. Have you tried staining the ILM under the PFCL, because you routinely do that under, and it does a good staining. So that reduces. And have you tried that any time?
Yes, you mean to stain with blue under PFCL?
Yes.
Yes, I did. I also tried that in other cases, and yes, it's good, because if you have PFCL with the retina flap, you can stain with dual blue or green or whatever under PFCL. Yes, I agree. In that case, I tried to remove PFCL, and retina stayed attached. Retina was not detaching. So I was lucky. But in another case, I agree with you. You can stain under PFCL directly. Yes.
So that was amazing. In spite of the hazy cornea, you were able to get a picture. I mean, you could get to the ILM. That's a tough one.
Yes, it was challenging. It was challenging.
Using a non-contact wide angle, Kim, if you have a small narrow rim of cornea with little clarity, you'll be able to see through that, and that's the advantage I think Dr. Matthew is using.
Yes,
Dr.
yes.
Zoran and Dr. Robert, any comments?
I totally agree with Professor Natarajan. The biome system or wide angle view system allows you to see even if you have a small cornea.
Small group, yeah.
Yes.
I would like just to comment about another strategy in the last case. Of course, I know Matteo, his experience, but more educational suggestions to younger colleagues. What about to treat retina, to perform iridoplasty, and to wait with IOL implantation as a second step when you are totally, so to say, sure about retina, you can control it, and then to consider maybe different kind of IOL or strategy to check refraction and so on. What do you think, Matteo? Of course, it is not about surgeons with such big experience, but alternative options, so to say.
Yes, yes. I agree, Robert, because sometimes this point of view, my strategy, as I showed you, of course, takes a lot of time because these are long operations. So I agree with Robert. You can divide first operation, just the retina part, and then you can deal for another operation second time for aphakia correction with IOL implantation and with iridoplastic technique. In the case that I showed you, the retina was attached. So in my experience, if the retina is attached, I prefer to close the case because if the retina is attached, if I implant the IOL immediately and I do iridoplasty immediately, I never operate the patient again. So in that case, I preferred to do everything because in this way, I didn't need to go back to operating room for the lens. But if you have a retinal detached, so if you have a detached retina, I think you can do like Robert said. So retinal detachment, you put the tamponite and maybe you can leave aphakia. Because you have to operate again for maybe for silicone oil removal, and then when you remove the silicone oil, you can implant the IOL and you can do iridoplasty. This is maybe easier for the surgeon. But in conclusion, I really believe that if you can do everything in the first operation, it's better because the tissue, for example, for iridoplasty, the iris tissue is still elastic. Maybe after 6 months later, when you will remove silicone oil, maybe you can find the iris tissue worse than before. So it can be rigid or you can find synechiae. So in the ideal world, I think it's better to do everything the first time. But of course, it's not ideal world. Sometimes you don't have time. Sometimes you don't have IOL. So you have to do a compromise. So Robert Redak, this is a practical point, very, very good point in the real life.
Dr. Zoran, you have any comments?
Yeah. Yes, I feel very familiar with Matteo Forlini's technique, and congratulations for nice videos. And the only thing that I wanted to add is my experience with visualization. I'm using the do you know about this last few years? Multifocal single-use biome lens. Do you know about it? It gives you a possibility. It gives you possibilities to, if you zoom out, to see the periphery. If you zoom in, you can use it as a central lens without need to change. Before that, I used Resight, but this one is even better. You can do everything with a single lens.
Oh, very nice. Thank you, Zoran, for.
Yes, this is
they're great videos.
I remember I tried this multifocal lens one time because the company gave me for a trial one day, and yes, I was very enthusiastic about that. So it's very helpful. Yes.
Yes, and you know, I use them in Sweden, and in Sweden you have a possibility to use it once, and they throw it. So I collect them and take to Serbia. If you need few of them, I can send you.
Okay.
Okay.
Thank
Great.
you.
Great videos. Actually, I would like to comment regarding the scleral fixated lens. We have designed a lens called scleral tuck lens, where two flippers of the foldable lens can be brought out of the scleral tissue, and without glue, without any suture, lens is retained for longer period of time.
Oh, very nice. Very interesting. What
I
is
can
the
share
name?
you the design.
What is the name of the lens?
Scleral tuck lens.
Okay, it's in Europe available?
I don't think so. It is patented in India.
Who manufactures?
I think Omni lenses. We have designed, and I'll share you the design with you, sir.
Okay, you can type it in the group. Okay.
Yeah.
I can play the next speaker, next video. Sai? Okay. So next we have our star performer, one of the, I think I'm happy we have a South American here, because I think my first webinar I did was on March 28th, and that was with Brazil, and my other friend Felipe from Chile. He's also online. He just texted me. So Dr. Hudson Akmara is a young vitreoretinal surgeon and working as the professor in Department of Retina and Vitreous, and he did his residency in ophthalmology in the Bank of Goya's Eye Bank, and then he he's trained in University of Toronto. Yesterday we had a Retinal Awesome 3, where he's the founder of it, and he with his teacher, Dr. Robert Deviani, who had an excellent presentation on an artificial retina on an Indian patient in Canada, and which he sent me a link. I'll probably send it to all. And now, Hudson, you can start your video. Sai, you can play the video.
Thank you for having me. It's a pleasure to be here. And the meeting yesterday from Retinal Awesome was great, as Dr. Natarajan said. And I'm going to talk to you about some ocular trauma surgeries. And are you going to be running the video, or do you want me to?
Sai, you can run the video.
Yeah, sure. That's fine. This case, yeah, this is a great case we did it 2 months ago. No, actually 1 month ago. And for intraocular foreign body gunshot, metal foreign body. And we had this corneal wound there, vertical one, as you see the vertical cut. And we wanted to locate the intraocular foreign bodies. The lesion was self-sealing. You have 2 foreign bodies over there. You can see from the CT. And you see actually the 2 foreign bodies in the ultrasound. You actually locate very accurately them. And you have one in the mid-vitreous and another one is stuck in the choroid that are very retinal periphery. The hexes was so tough to do. And of course, we knew there were a posterior capsule lesion, so we had the vitreous anterior chamber. And I don't use triamcinolone blue, and I can get away with the vitreous and pretty well, but the vitreous from these trauma lesions is very adherent, as you see. And you can see there the lesion from the trauma, and you see the foreign body inside the eye, and the first foreign body. The first foreign body was a smaller one, so it was not difficult to handle it. And oftentimes the media gets a little hazy, but we use this crocodile 23 gauge forceps to get and remove the intraocular foreign body. This was a not very large one. As you see, it's over the cornea. But you know, even a small one, it's difficult you have to remove it. And now the second one was stuck at the choroid, and we were able to see through wide-angle vitrectomy viewing systems. And it was a larger one. Still, with the crocodile forceps, we could remove it, and we had to enlarge the sclera for that purpose. And it came out softly. But we were trying to find maybe another foreign body, you know, we have to insist. But we had this peripheral retinal detachment, and we used the fluorocarbon to attach the retina. as you see. And now we're going to go on with the laser and the laser. We did this barrier laser, and the retina remained attached all the time. And we did a direct silicone oil PFO removal. I think you could, I think the video stopped for a while. I think you could forward the video a bit. It stopped for me here. And but just commenting on this video, I like doing direct exchange. So I insert fluorocarbon at the same time I remove. I insert the silicone oil and remove the PFO at the same time, and so I don't have any slippage. If we have a retinal detachment, this laser was made under silicone oil, and the post-operative period, the retina was fully attached, and the patient happy. And we're gonna wait for a couple of more months to remove the silicone oil and implant the secondary implant and intraocular lens. This was a great case, and I didn't have any PVR when the patient is on corticoids as well, and the media is clear, and so he's getting better every day. And we are just waiting because he's a young man, 23 years old, probably 23, 25, and he will have the lens implanted after we remove the silicone oil, because the macula is so good, looks good, and he's happy with the results. And if you want, this video was made in 4K, but the first one. Let me see the second one. If you want to play it, I'm ready. It's a traumatic endophthalmitis. The patient had the lesion, the corneal lesion, and no, this is the third one. Yeah, now you have the, this is a Terson syndrome, vitreous hemorrhage. You have the vitreous stuck, and very difficult to remove it. But as I said, I can get away with that without the dyeing the vitreous, and the vitreous seems to be stuck and very difficult to remove, but still not applying too much force on the macula and avoid interactions. You remove the vitreous from core vitrectomy at first, and then the media looks quite hazy, but it's getting better. And now I'm going to use this macular lens so I can get a much better view from the macula with this is a wide angle lens. Now we're removing the vitreous attached there. The media is a little hazy, but after I use the macula lens, the vision is going to get a lot better, and I'm going to be able to use brilliant blue, and even if I wanted to dye the ILM, but I can with the macula lens, as you're going to see in a few seconds. With the macula lens, you see the ILM, you see the reflex out of the retina. So I'm still removing the attached highlight. Now you see here the ILM, and without using the brilliant blue, as you see, I can, with the cutter, have the ILM removed. And that was awesome because it's so difficult to do that. And I got an edge, and I'm here moving the ILM with the cutter. And I just lift it up and removing the ILM this way. So I'm removing the ILM now, and I'm freeing up the macular area. And of course, I don't want to leave that there, otherwise I could have some PVR. And then we have this peripheral hole. So with the wide angle system, it's easier to see it. And I did the laser around the hole. And we carried on the vitrectomy with only air fluid exchange. And it was a cool case. We didn't need to put silicone oil. So that went well. This patient was operated. They had their operation for the two eyes. This was the first operation, the other eye. We did virtually the same thing, except for the ILM that was not needed to be removed. In this case, we removed the ILM without using the brilliant blue. And yeah, that went fine. The patient got 20/40 plus with correction, and he was still phakic without developing a cataract. Very nice one. And let me see, this is traumatic endophthalmitis. This is a case I did, I think, 2 or 3 years ago. And this is my boy crying over there. You see here, traumatic endophthalmitis. We are at the Eye Bank Foundation in Goiânia, Brazil. And we have the corneal suture, but then he got the media hazy. We have the stellaris vitrector, and you saw these clusters of infection all over the eye, the posterior pole, and attached on the hyaloid. It was difficult also to remove them, but still, as I say, I don't use the, I have to catch one by one, as you see the fungal infection we use to amikacin, and also all antibiotics possible, and ceftazidime, vancomycin to treat this. But we had to remove one by one, and we have to do a good core vitrectomy and peripheral vitrectomy to get away with these opacities as well, and during some laser to protect the retina, and also we did injections just after laser and just after the surgery. And the patient is cool, is very good. And after the surgery, he went for some systemic treatment as well. And as you see, he's still phakic, and he did not develop much of a cataract. And he's getting better. You know, it's some time I don't see him, but he was okay by the last time I saw him. So we saved the eye because we cannot wait too much to treat traumatic endophthalmitis. Now the next case. Yeah, this is perfluorocarbon. We are using the perfluorocarbon to lead this is a traumatic macular hole. This I'm playing this to show you how hard is it to remove the ILM when you have a traumatic macular hole. The ILM gets so stuck, so difficult, and you need a very good macular lens after brilliant blue that are inserted inside the eye. And then we did another air fluid exchange. I like doing a complete air fluid exchange, because with a complete air fluid exchange, the retina, the ILM gets so good to see. This is a large lens. This is a mainstay lens, a very big one. But you have such a great and wide angle view. I love using this because you seem to be inside the retina. And so you have the retina, very big, very large image here now, and the wide angle. So it's cool. And as you see, the ILM is stuck around the traumatic macular hole. This patient was counting fingers, but he got better to 2,400, which is not so good. But the hole closed, not 100%, but he got better, and the media was too hazy, and we removed the vitreous, and we treated the macular hole. So it's not easy to get the ILM because it's stuck here, stuck there. It's a kind of fibrous tissue around. So you have to look for the good edges and very slow, not to develop any trauma around the hole. And as you see, we are completing the spiny movement around the macular hole, and did some endolaser around. We did not find a defect or retinal detachment, but we like for trauma cases doing the 360, mostly lasers, and not too much, not to get the PVR. And finally, we did air fluid exchange. The retina was attached, and the case was good. And I'm still following this patient, and the vision is stable. And now this case is it's a dislocated traumatic lens. And I was watching with Natarajan yesterday a retinosome from the Japanese Oshima, Yusuke Oshima. You know, I'm going to do a different approach. I'm doing the vitrectomy, and I'm going to remove the dislocated lens. But then I'm going to comment at the end of my presentation his technique as well. It's very interesting, his technique. But my technique, you see, the patient was aphakic because the lens was inside the macula, and I like doing the core peripheral vitrectomy first. I don't go straight to the lens, otherwise I would cause this trauma on the retina. I like using when the lens is on the macula peripheral carbon liquid. So you lift way towards the periphery, the lens, and you get a very good image here. And so after vitrectomy, the complete vitrectomy, I'll go after the lens. So my baby's crying. I think he doesn't like it. You see the lens around, and now I'm gonna go after the lens. And with the cutter, I go inside the lens, and I get, now it's stuck on the cutter, and then I use the fragmentum to get away with that, because it was not so soft, not so hard. So with the fragmentum, it was removed so easy, because fragmentum, you do that in maybe 15 seconds. It's so fast, depending on the power used. And then we went on with vitrectomy, removing all perfluorocarbon droplets. Some perfluorocarbon, they stay on the macula, and so you have to remove them all. And I use macular lens to remove all perfluorocarbon, to don't leave anything. And the macular lens is the best lens for you if you want to see if you have left any perfluorocarbon liquid inside the eye. And at the end of the case, we did endolaser here. As you see, endolaser in the retinal periphery to protect. We don't always know where, this lens was floating around the eye, and so it's better. And then we finished the case with the fluid exchange. And I just want to comment now with the case we saw from Oshima yesterday, which was funny, because very fancy technique. He used, 10,000 cuts. He, with the forceps, the retinal forceps, he introduced the forceps inside the lens, and then with the cutter, he was cutting on the lens, when the lens was stuck inside the instrument. And he said this was the barbecue technique. So he could get away. You remember, Natarajan? He could remove the lens with virtually no trauma. Interesting, because 10,000 cuts is too much for me, I prefer to use less cuts, less opening and closing, so that you can remove the lens easier. But his technique was so awesome that he was very good at that technique. So thank you very much for your attention, and I'm available for.
Thank you, Hudson, for a wonderful videos, Dr. Kim. And I think this time we want Dr. Purendra and Dr. Gangadhar. I know they are not retina surgeons, but to comment, but Kim to start the discussion.
You're on mute. You're on mute, Dr. Kim.
Yes, okay.
Excellent videos, Dr. Hudson, and variety of cases. I just want to ask you, in that macular hole surgery case, the traumatic macular hole, there seemed to be a thick fibrosis and the macula, just, temporal to the fovea. Was that there, or was it just or if it was there, would you do about it? Fibrosis?
Oh yeah, I sorry, I didn't hear much because my baby was here crying. Can you repeat? For
traumatic macular hole surgery, I just saw a thick subretinal fibrosis just temporal to the fovea. Did you have to remove it, or you just left it at that? Because
It's usually for traumatic macular holes. It's very, very stuck, the ILM there. But I have a technique that I sent for the Brazilian Congress. It's called foveal peel. So I start right at the fovea. People usually avoid the fovea, going around and then approaching the fovea. Usually those cases, you have to go towards the fovea, because the ILM is so stuck. You have the fibrous tissue just crossing the foveal area. And I have this pinch and lift, I call it the tear and lift technique. I just create a small tear, and from that tear, I go on with whatever position is less attached. And so we keep opening. In some cases, you have to do that, even with epiretinal membranes, because sometimes they are so grinding, so stuck. In this case, I could cross the fovea, and then I had to pick another area and cross the fovea again. And so I completed the whole thing. And it's not easy. As you said, it's more difficult. And I prefer to do 100% air fluid exchange before using the bleed and blue to have a very good view from the macro area. And it stays bluish, very good to get it.
Another quick question on the traumatic endophthalmitis case. Do you use lasers in those cases? Because usually it's inflamed eye. Would you still want to use it in an eye where the retina is well attached? Or what is the
I like using cases just in case, not for all cases. I do laser 360 degrees. But whenever I do vitrectomy, I like using the laser where I enter, like at the sclerotomy sites, at 10 o'clock, 2 o'clock, and then infratemporal. I like doing laser there just in case. But sometimes you have some traction, some you have to do more laser. But I like doing that because you never know whether you caused any iatrogenic peripheral break, even though I take a very good look. And we have these wide angle systems today. So it's not so, you usually don't leave any breaks over there, but I like doing just in case, just a preventative measure.
Thank you. Thank you.
Dr. Ravi? Yeah, Ravi?
Dr. Hudson, those were amazing cases. 2 questions. One, what was the cause of the Terson syndrome in that patient? And second, what do you think is the optimal timing for vitrectomy in Terson syndrome patients?
Yeah, this case, for the case that I showed, I did the patient had an accident, a car accident, and he was vitreous hemorrhage for the 2 eyes, and it was good. The first case I presented in iTube, and it is there. A very good case that I could lift off the ILM, and that was the cause. I think for vitreous hemorrhage, even though it's attached, you can get away with that with a good vitrectomy. And the patient was phakic, and we didn't need to do the cataract surgery for him. He's cool. And what was the second question, please?
What do you think is the optimal timing for vitrectomy?
Oh yeah, the optimal time. Yeah, okay. But this patient had this vitreous hemorrhage. He was not seeing out of the 2 eyes. So vitreous hemorrhage, very, dense in both eyes. So it took me maybe 1.5 months. I was doing ultrasounds. The hemorrhage was not getting better at all. So I decided to do 1 eye, and then we would be waiting for the other eye. Maybe that could resolve, but that never happened. So after 1 month after the first surgery, we did the second surgery, and everything went well. I was fortunate to get the ILM with the cutter. I had never seen that before, and so I got stuck. But maybe because of the trauma, the ILM got more, loose. And so I could lift it off and remove it with the cutter.
Yes, I think Hudson and Ravi, one particular peculiar thing about, I always tell the fellows that the vitreous hemorrhage in a Terson syndrome is not simple because there's no PVD. I don't know what's the reason. I think the hemorrhage coming through the pia, through the optic nerve, I think there's some etiology on that. So there's no PVD. So I think a beginner surgeon should not attempt a Terson syndrome. And I suggest an experienced surgeon, not because of whether the complications of inducing PVD. And Ravi, I think you should comment on the gunshot injury and what's happening in the US.
Oh, sure. Yeah. So I'm not sure what the world view is, but in the last month we've had peaceful protests throughout the country, and the American Academy of Ophthalmology, I'm speaking as an individual, has collected about 20 cases of rubber bullet and tear gas injuries in the U.S. So this has become, we've started a campaign called No Rubber Bullets, but this has been a big problem where I think the rubber bullets is a misnomer. I think the authorities are pointing the rubber bullets at the patients instead of at the at the peaceful protesters instead of at the ground. So we've seen significant injury. I haven't operated on any of them, but it is a big movement in the U.S. to try to prevent no rubber bullets.
And, Hudson, what in your bullet injury, in the gunshot injury, there was a metal foreign body, but in the US they used rubber bullet, and in Kashmir they used pellets. So how come you had a metal in the eye?
We had this metal foreign body because it was a gunshot injury. This guy was not playing, he was around, and it was a police pursuit, and he was around. And somebody gave a shot, and he was close, and the bullet got inside his eye through the cornea wound, a self-sealing one, and the like spread all over the eye. And fortunately, only two foreign bodies, metal foreign bodies, got inside his eyes, and he was in the wrong place at the wrong time. And that was what happened. It was not a shot straight into his eye, but he was around.
Ashok, you want to say something?
Yeah, I wanted to know from Ravi, what kind of injuries are you seeing? Are they concussion injuries, or are you seeing any open globe injuries as well?
There have been open globe injuries. The one patient that became famous on Twitter, they thought was a rubber bullet injury, but it was actually he went down. Apparently, he went down toward the tear gas canister, which exploded and caused that sort of injury. So. The cases that the Academy is collecting, we don't have all the details because of patient privacy and that sort of thing. But I think that many of the eyes are being enucleated a few days later because of the type of injuries that you're seeing. So it's really it's terrible. It's terrible tragedy here.
So actually, because of Ravi, the American Academy president has quoted his own blog, as well as in the American Academy the newsletter sent on June 3rd, carries the New York Times article which covers my work and Dr. Tariq Qureshi's work. Thanks to Ravi, and also it quotes the Chile's thing. And we don't have an answer. What do we do to prevent? So we had a discussion with OSN and also called intravitreal expert group in Europe for telling the police should do something novel to prevent this blinding injury, and also the people should do protest and protect their eyes.
This will need a global campaign.
Yeah, yes. I think the Trauma Society should take it up. Both, I think there's an American Society of Ocular Trauma, which myself and Gangadhar are getting part of it. And we had a meeting with the American Academy last year with the trauma experts during our meeting. Gangadhar is here. So we have to do something. And I think in India, unfortunately, when we circulated, people ask question, what did you do in India? We have not done anything in advocacy because it's very, very sensitive between the government and the public here. So we are only talking about how we repair, and we're not talking anything about
these are not so common now.
Oh, yeah. I'm happy. So, Purendra, you want to say something? Purendra? Dr. Mukherjee is saying something.
Yeah, actually, I just like to request you that just cut down a little bit of discussion. We are running short of time.
Sure. So we can go to the next speaker. Sai?
Next speaker is Dr. Natarajan. And I'll introduce him. He does not need any introduction.
Yes, I think so. You can skip.
Padma Shri. He is a Padma Shri awardee, and he is one of the fellow who has changed the Indian ophthalmology, All India Ophthalmic Society. He has many more credentials on his name. We will not enumerate that, but most important parts are that he has got large number of presentation, publications, and book chapters. He acquired many awards, and he has a large experience for more than 60,000 vitrectomies. And his work in Jammu and Kashmir was exemplary, and which has got the recognition all across the world. And he has performed live surgeries in almost all parts of the world, and more than 1,500 invited guest lectures, and conducted more than 60 instruction courses. So this was just a formal, but we know all of him. He is a highly dynamic fellow and full of energy. One thing which is not enlisted here is he is fond of chilies.
Right. Can we have the video? Thank you, Mehul. And I'm glad we can start the video. This is the injury. You can see the corneal sutures. Right now, Dr. Kavita Rao, my associate, is doing the phacoemulsification because this patient had an injury. We decided internationally, along with Ferenc Kuhn and Fernando Arviolo, that we will do the primary wound repair immediately, and then within 6 days to 8 days, we'll do the secondary intervention. So this was the 8th day. The patient came from Kashmir to Mumbai, and actually there were only 1 or 2 patients who came. Rest of the patients, I said, to be in Kashmir, I'll come there and operate. So I think in first visit, I did 47 vitreoretinal surgeries in 3 days, thanks to Dr. Tariq, Professor Tariq. And you can see here, after doing the phaco IOL, I go ahead with the 23 gauge, and I'm actually using perfluorocarbon liquid after vitrectomy. There was a submacular hemorrhage. I make a fine retinotomy using a 39 gauge needle, which is used for subretinal injection, and I go behind and drain the submacular hemorrhage. And just because it's a week old, we can drain it and clear the macula. Rest of the subretinal hemorrhage, we leave it like that, and we drain and then we make sure the retina is attached and do a endolaser around that small microretinotomy, which is done away from the macula. And then I used silicone oil for this patient. And because of this corneal astigmatism, this patient got about 3/60. And I hope with the corneal treatment later, I hope the patient will improve well. So as Matthew mentioned, we did everything together in second surgery, like phaco IOL, vitrectomy, submacular drainage, and silicone oil injection. And then about 3 months later, the silicone oil was removed. Next. And here the pellet had actually gone through and through into the orbit. There was no pellet in the eye. And this is a 23 gauge vitrectomy done for the pellet ocular trauma. Again, thanks to Dr. Tariq Qureshi for recording it and giving it to me, where they had everything, the Zeiss microscope, the wide angle, they had the Zeiss wide angle system, recite, and then you can see there's a play in near the macula. There was the site of impact. I think when the pellet comes, it goes straight, hits the part of the macula, and then falls down. So what I did is I modified the technique where when I see the pellet within the vitreous hemorrhage, which is little anterior, I made sure that I come out, make a conjunctival opening in the 11:1. Thanks to Dr. Sabia, who's there in the department, who suggested, why do you want to enlarge the sclerotomy? Instead, you can have a separate incision. That's what most of the trauma surgeons you saw doing it. I completed as much as vitrectomy possible, but I left the pellet within the vitreous hemorrhage. And then I actually go through the 11:1 conjunctival incision, followed by a scleral incision, and use the forceps designed by my colleague, Dr. Manish Bapaye, and Mahesh Shanmugam, and myself, which I don't have any financial interest. It is made by the company in India, where it's a 4-pronged forceps, which I now grasp it. You can see I'm grasping it within the vitreous hemorrhage. The idea is if I remove the vitreous totally, the pellet will fall down and roll on the surface of retina, which I don't want to do. So I tease the vitreous hemorrhage, which is attached, and then now I've grasped the irregular 4x4 millimeter shaped pellet, which I removed through it's a phakic. Most of the people were 15 to 21 years old, and this is a 4-prong. And then I close the scleral wound, the conjunctival wound, and again re-enter, complete the vitreous base excision, complete the PVD, and make sure that the exit wound, if it's there, or the impact wound, do an endolaser around it so that you can do a fluid air exchange and leave it. The next one, I have a third video. So this is a third video. We can see in this, we'll be seeing it's an phakic eye, where you see the corneal wound, where you can see the corneal wound and a phakic eye. And in the first one, the wound repair is done along with the lensectomy. Then so second surgery, I'm directly going after completing partial vitrectomy, again grasping the pellet, which was there. I think rarely we found 2 pellets. Most of the pellets had gone through and through and got into the orbit. And you can see here the pellet is removed. And I think many eyes got better than 20/80 or 6/18. Some have only 3/60. Few had only hand motion. But I think our aim was to have a spare tire because they're all 15 to 21. We expect them to live another 60 to 80 years and make sure that we do the best. And I never give up. And I wanted to comment on Ravi's, which I want to urge to the American surgeons. even though they have enucleated in 2 days. I somehow don't like to enucleate an eye in the first few months. I do everything to prevent sympathetic ophthalmia. That means if there's a UVL injury, make sure that the UVL is not there in the wound repair, and make sure you do a meticulous repair. Maybe you take 3 hours, 4 hours. It looks like it's a gone case. But I think my suggestion is you should do, you can see here this eye, you can see the wound where the pellet had gone through and through and gone into the, and it's actually luckily next to the optic disc. And I'm clearing the vitreous there. And I make sure that there's no vitreous incarcerated there to prevent any neovascularization happening. Do a laser like doing a coloboma choroid, and that's the exit wound. Fortunately, this eye, these sort of eyes get 6'9", 6'12" with an intraocular lens as a second surgery. Maybe you have to do 2 surgeries, 3 surgeries. And I think some surgery, even if there's no PL, I do a vitrectomy and do whatever I can. And even if they get from no PL to PL, it's an achievement according to me and to the patient, because living in a dark world and having some sunlight you can see, I think it's a great thing for the patient. And you can see the retina attached here under air, and then a wide angle helps you to do everything well. And I think however bad the trauma is, and that's what the New York Times covered it, and I'm happy I could support the Department of Ophthalmology in Sri Hari Singh, Maharaja Hari Singh Hospital, where the ophthalmologists had a tough time to answer the journalists. But I think I learned from advocacy from the leadership program from American Academy to face them. And I told them that I'm coming as a surgeon, like I see in the Second World War, where the Red Cross people go there to save patients. I've come as a surgeon to save the eyes, and don't ask me more questions. I can answer on how to repair and how to prevent. Thank you. Ravi.
Tarajan.
Yes, sir.
Great case. I want to ask you, the forceps you use to remove, I use that forceps. I have the, when the intraocular foreign body is irregular and large, I open for 20G, and I have this forceps from Rumex that opens and closes and grabs the metal foreign body. I think he used the same one. And my case, I was using the crocodile forceps, but you know, when the foreign body is so irregular, we cannot get away with that without having a very good, you know, large intraocular foreign body forceps. And what's the make of it? It's from India?
This is a lead. No, the forceps is made of India by a company called Epsilon. They also have a branch in US. As I said, no financial interest. It is designed by Dr. Mahesh Shanmugam, and it's published in Indian Journal of Ophthalmology. It's a 4-pronged forceps. Earlier, I think 20 years back, there was a 3-pronged forceps. I think it's modified and made a 4-prong. Fortunately, the lead pellet was like something like a 4 into 4 millimeter polygonal, but fortunately similar shape, which was able to grasp it, and exactly like a basket, it was grasping. And he got his idea from his father, who's a urologist, and his mother is an ophthalmologist.
23G?
It's a no. If you see, I have made an incision from 11 to 1. So I made almost a 5 millimeter incision, and this is not 20. It's bigger than that. So the idea was because it's a 4 millimeter by 4 millimeter, maybe some angles it will be 5. So I better to do 7 millimeter so that it's a liberal incision done, and make sure you have a good base excision so that you don't have retinal dialysis in future. Ravi, you have any comment?
Sir, I would like to comment. We have published a series of 400 plus cases and improved 29, all were no PL cases. 29% cases improved vision from PL2 to 60.
Okay, yes.
Oh. So that has been published in Journal of Retina Vitreous.
Very good. Okay.
Can I ask a question, comment?
Yes, Ganga.
Yeah, no, it's simply amazing. I think I was just commenting that vitreoretinal surgery was my second specialty when I applied for fellowships.
Oh.
If I had done orbit and ocular plastic surgery, I would have done VR surgery, and now I'm thinking, should I have applied it as a first specialty?
It was reverse for me. My father wanted to be me to be an oculoplastic surgeon. I don't know why, but I hated it. I don't know why, because my first publication was on ocular rhinosporidiosis with Nirmala Subramaniam, who was a plastic surgeon.
Anyway, regardless, hats off to all the presenters, all the wonderful videos. It shows the skill set that goes along with the thought process. I think, and we are also learning to push barriers. And there's textbook ophthalmology and there's ophthalmology beyond textbooks. And I think we need mavericks who push the frontiers. I think we do burn our fingers sometimes. We probably blind some eyes in the process. But I think that's how science prolongs and moves forward. So compliments. Just a couple of questions. You're talking about the intraocular foreign body, which is a perforating injury. Now the foreign body inside the orbit. Is there any effort taken to remove it, or the advice is to leave it alone? Or have you ever removed an intraorbital foreign body which has gone through the posterior pole of the eye from the orbit through the eye? Has anybody ever done that?
Yeah.
And the last question is about sympathetic ophthalmia. I know it has been a hot topic in the past. Then the pendulum swung and said sympathetic ophthalmia doesn't exist, or even if it exists, can be easily managed. Professor Peter McCluskey from Sydney is giving a talk at WOC and really saying that SO is no longer an issue. We can always manage it anytime. And the final question to vitreoretinal surgeons is there any intraocular foreign body you always say best left alone? Because we orbital surgeons sometimes decide that. Thank you.
Yeah, the first question is about any orbit you removed. Pellets we don't remove because people generally have multiple pellets on the face, body, and we have decided not to touch it except when some pellets produce some pain in the skin. But same thing happens to the orbit also. Even though lead is there, I don't think any reaction has been reported till now. And I think the first pellet injury happened in 2010. And there are some publications from Iraq also in 2012 and then 16. So I think nobody reported any problem in orbit. But I have a case where I did with Rupali. We did everything. We thought the foreign body was intraocular. We couldn't find out. We did a CT. We had everything on the side. And then we searched, we didn't get. And I called Rupali to search in the orbit. She didn't get. Can you believe? 3 hours we struggled and we closed the case. And then after that, we did repeat CT and then she did surgery. And I don't know how, what we see in CT, you can't see it in the eye. And I don't know whether it's because of the real bloody messy field. I don't know what's it, but we got it later. Similarly, I had another patient where the iron, because the wire was seen in the limbus, and it was happened in a public hospital. And then the resident saw it and then pushed it in. By the time he taking it, pushed it in, went into the angle, and they clearly demonstrated in ultrasound. But me and my other surgeon, Dr. Sachin Darwekar, I don't know whether he's seeing, we tried for 3 hours. Then I told him, I think enough of meddling. And then since we cannot see, ophthalmology should not, I remember that from my father, that no surgery should be done in blindly. So I think we were like blind. We couldn't see the foreign body. So finally, we referred to Dr. Reddy in LV Prasad to use the endoscope. My endoscope didn't work. So he located it by endoscope and then removed it. So I think there should not be ego. And the third question is about, what is the third question? Ganga?
What is to be left alone? Which foreign body is to be left alone?
Usually, I think if it is a gold, it's better to leave it alone because the original surgery says that if you remove the gold, it's your surgeon's. It's not the patient. So anyhow, jokes apart, but I think if you have seen the first IOL came after the blast injury from the plane, where that means if it is a glass foreign body and not, or an acrylic foreign body, which is not producing any reaction, no trauma to the any structure you can leave behind. But now because the surgery is so advanced, if you see a foreign body which is going to produce mechanically a problem, then we remove it. I remember, I think when I was a visiting surgeon in Malaysia, I have that video where the injury happened in Nigeria, wound repair done there, second surgery was done somewhere. He came with aphakia and with the inferior detachment. And I did a base excision. I was shocked to see because in ultrasound, the foreign body was not seen and clinically couldn't see. And there was I was doing a base excision. I thought something glistening was there. And finally, it was a big glass piece. And when I removed it, behind that was a large dialysis, but there was probably a leak and inferior detachment happened. So I removed the glass foreign body through the pars plana and then did a PFCL oil. And then after that, I removed the oil. And the patient wanted a secondary IOL. I refused. I said, come on, you have saved the eye. You got contact lens 636 and he wants a secondary IOL. Anyhow, maybe 1 year later, he would have got it done because now I don't go to Malaysia. So I think I only want, that's what I want to convey to Dr. Ravi, to convey to the academy, and maybe we should have some publication do not enucleate in the first 2 weeks. I think you can prevent. That was a final question by you about sympathetic ophthalmia. I don't know whether you know the most famous case, or one of the case which happened in the world for a medical is sympathetic ophthalmia missed, and an Australian surgeon was fined few $1 million. And I think it was a worst case scenario because for the reason he was not mentioned. So I, from that time, take a video consent for trauma patients as well as a written consent in their mother tongue about sympathetic ophthalmia, even though it's very rare. I think it happens. And I should say, I have seen sympathetic ophthalmia following vitrectomy in my own patient, 3 patients. So only thing is, I still remember Parson, the one paragraph given there. The reading vision will be the first to be affected in the sympathizing eye. I think we should detect that day and treat the sympathetic ophthalmia like a very severe uveitis with antimitotic drugs, and you can treat it. And there is an article by Urayama et al. From Japan saying that you can treat sympathetic ophthalmia as a bilateral uveitis. So I think you have to treat in time. It is like the siderosis. You pick up in time, you can treat. I have operated a patient with siderosis, removing the foreign body, and there are reports which says after you remove a foreign body, iron foreign body, after removing siderosis sets in, it will continue. I don't know how it continues, it continues. So best is to remove immediately. So leaving the foreign body only in the orbit, I think orbit, forgives everybody. Nothing happens likely in the eye. Even sometimes, rarely, I think the iron foreign bodies have produced siderosis in the orbit, which is very, very rare. And I think those eyes, orbital surgeons can remove like you. So I think for fear of sympathetic ophthalmia, we should not enucleate, however bad is the injury. And I think in 1984, Michael Belkin from Israel has already published that time. But somehow, even now, people do enucleation or evisceration. I hope through this international webinar, I want to convey one take-home lesson. Do the repair. It's like, I remember a famous saying, a fellow is in semi-coma and multiple bodily injury, and the fellow says, because they move the trolley like here and there as though he's going to die. So he says, when he comes into the conscience for a minute to the anesthetist, please, for heaven's sake, operate me as though I'm alive. Don't treat me like a dead body. So I think don't treat the eye as a gone. I think whatever may be there, I think you can use any number of Robert Morris and Ferenc Kuhn has published several articles where salvaging the unsalvageable, operating on no PL eyes, and from no PL, vision has come up to 660 or even 618, and also maybe remain PL. That's okay. And in case you see 6 months later, if the eye becomes thiazical, we can refer to Gangadhar Sundar for doing a reconstruction. Yes, Ravi.
Thank you. Thank you very much.
Ravi, you want to say something?
Now, this was an amazing symposium. I do want to say hello to Dr. Kim because I traveled to Aravind twice as a resident, once to do 68 extra caps and then second time to do phaco surgery in the late 90s and early 2000s. But the spirit of learning and the love of learning, I think I think that's the biggest there can be a benefit of COVID, but to bring our societies together is absolutely amazing. So that's the only thank you I want to say. But
I can see in the background photograph with you in the academy. Great, thank you.
Yeah. I got some Taj Mahal, India Gate right there. You know, so no, it's a huge honor to be.
Mukherjee is probably calling the next speaker.
The next speaker is Zoran.
Yeah. So Dr. Zoran Tomic from Belgrade, Serbia, and if you have known that Serbia is a old Yugoslavia, and he was very close to and did his fellowship with Dr. Ralja Jovanovic, my favorite mentor, and even now he's doing gardening, and I saw just commenting on it, and he's also spent time observing Dr. Robert McAmer, and he's written several articles published, and he's got 170 scientific publications and scientific presentation and 34 published paper, and has a wide variety of experience with 14,000 vitrectomies, including 22 macular translocations. And I think he's a versatile surgeon, and I think he and few of us have watched Dr. Jovanovic, and I think learned a lot, because Dr. Jovanovic spends every second talking about surgery all the time, whether it is in the operating room or in the outpatient, and he used to do only one OPD a week, and then rest of the time in the evening discussion. And any course, if you go with him from morning to night and from again next day, I think he will talk about vitreous surgery. And I think we both have learned a lot from Dr. Jovanovic, and I'm with this Dr. Zoran, we welcome you to present.
Thank you, Natarjan. I would like to present 4 cases, and the first one, can you run the video, please? The first one is a corneal perforation due to assault where the cornea was completely destroyed. So I decided to do eccentric PK because this nasal part of the cornea was completely destroyed, and I want to emphasize it a little bit with the PK. And then I used the Eckert's keratoprosthesis to start with, because the visuality in visualization in the eye was terrible. So when I started, I realized that retina was completely detached and the funnel-shaped detachment occurred. So I had to create the space because the whole retina was incarcerated in the proliferation wound. So I did the 360 retinotomy. The case was performed 3 weeks after surgery because it was referred to me from another center. So when I entered the eye and did the retinotomy, I was able to realize the subretinal strands that already formed. So I removed them and mobilized the retina. That was a young male patient that suffered that injury, 22 years old. And then we attached his retina using PFO. And after that, we did the 360 laser consisting of 3 rows of laser effects. And after that, when completing the rear segment and leaving PFO with the eye, we continued with the keratoplasty. And my idea was to probably replace this PK with the central one, but it was not necessary because the vision was not that good. So we just left that as it was the eccentric PK. And I sutured it with the 10-0 interrupted nylon sutures and injected the silicone oil at the end of the operation. After 3 months, we did the silicone oil removal, and the case finished with the 360 visual acuity. We can continue with the second case. That was the foreign body, metallic foreign body that was did the corneal perforation and that healed by itself. We did the cataract surgery of a traumatic cataract. And then we came into the vitreous cavity, did the PVD, and it was possible to visualize it because the warm intraocular body did the diathermy. So we mobilized the metallic foreign body and did the bimanual extraction using endomagnet and intraocular forceps. We enlarged the sclerotomy and removed it. Did the laser around and finished with the air tamponade. At the end, since the posterior capsule was injured, I did the implantation of 3-piece MXT lens in the sulcus. The final visual acuity of this patient was 0.8. And the second one was the case with the foreign body that was non-magnetic. And here the lens was so injured that we did the pulse plane lensectomy, and then vitreous hemorrhage was found. And doing the peripheral shaping, we found the wire that caused all this. That was an aluminum metal wire, non-magnetic. So we pulled out this using the forceps as well. And after this removal, we continued with the, you will see soon, laser around this scar area, but he developed traction retinal detachments, and we did completing of surgery with focal retinotomy and removal of this scarring area with scissors and forceps, and then the Meter's cutter. I flattened the retina with the PFO and did the laser. And after that, silicone oil injection. During silicone oil removal, we completed the case with a secondary IOL implantation. This is a corneal perforation together with the traumatic cataract that we remove, and then we didn't know exactly where the foreign body was, but then we found it with indentation that it was in the lower part, anterior to ora serrata in pars plana, and we removed just using this bimanual technique of two instruments, endomagnet and forceps for intraocular foreign bodies, and finished case with the air tamponade only. So now we have another case of the traffic accident. The lens was dislocated in the eye. There was a dense vitreous hemorrhage. That's the reason I decided to do translingual vitrectomy. And when we opened the posterior hyaloid, we found the total retinal detachment and massive subretinal hemorrhage. When we, with several tears in the periphery, well, when we removed the membranes, and then saw that there was a big clot of blood and some liquefied blood as well under the retina, we decided to do 360 retinotomy in order to clean the subretinal space. And after removal of some membranes and the big clot you will see soon, we managed to clean all the space. There were two bigger clots that were removed. This one as well. As you see, we are using the chandelier light and the bimanual work. And then we flattened the retina using PFO, and some folds were formed in the nasal part, which was unfolded using a flute needle with silicone tip, 360 laser. And after that, we decided to work in the anterior segments, leaving the PFO in the eye to stabilize the pressure in the eye when we completed the laser 360 around. So we did the pupilloplasty using the 10 zero ProLens suture and straight needle. And through the corneal incision, we tightened the knots to in that manner, we were able to form the plate for intraocular lens implantation of iris glow lens behind the pupil. And we finished this operation with silicone oil tamponade. After silicone oil removal, the patient gained the visual acuity of 460 and was stable. We can continue with the next case, please. And this is the traction retinal detachment due to assault, knife. And there was incarceration of the retina in the scleral bounds. So we did the retinotomy in this part with the scissors and cutter. And then we realized that there was a giant tear on the opposite side. And again, we had one 360 retinotomy and some subretinal strands. The patient was operated 2 weeks after injury and primary suturing in another clinic. We flattened the retina with PFO. And then when we entered PFO, we saw that there was a leakage of PFO, which told us that the scleral wall was not very well sutured. So we decided to do the scleral patch in order to make the stable pressure and situation in the eye. And this scleral patch was made of pericardial tutoplast. And it helped us to maintain the pressure and to see the eye. We put the sutures taking a temporal position of the microscope. And then after that, we did the flattening of the retina with some massage because macula was dislocated, and we did the relocation of the macula and unfolding of the retinal folds. And when we managed to do all this, we did the laser 360 in this case as well. We do not perform 360 no trauma cases, but those were quite complicated cases, so we had to do it in the cases, some of cases I showed you. And after 360, we did the silicone oil injection. Silicone oil was successfully removed 3 or 4 months after the surgery, and the final visual acuity was 260, but the eye was saved. So those are the cases I wanted to show you. Thank you.
Excellent surgery, Zoran.
Thank you.
Excellent, Zoran.
Thank you.
And Purendra, I think you have any comments? You're not spoken. You have to unmute, Purendra. No, you have to unmute. No.
Yeah, it's all amazing bouquet of surgeries we are seeing from all variety of great surgeons from all over the world. I really appreciate everybody's efforts, and the way I think what you have already earlier said that even if the patient is no PL, we should try once, and we should not do inoculation or evisceration in such cases, and we should try at least. And that is what is the message of this webinar, what I feel. And amazing surgery, really. I mean, it was so good that for us, it was anterior segment surgeon. It was amazing to see all these variety of surgeries with good results. Thank you.
I have one question to ask to everybody. That has anyone seen expulsive hemorrhage in open globe injury during surgery?
I have had a expulsive hemorrhage post 1 day wound repair done in Lucknow. 24 hours later, came back. He was a principal secretary of government. His father, 86 years old, while doing vitrectomy, the expulsive happened. I didn't know first. I thought it was a suprachoroidal effusion happening, but it was expulsive hemorrhage. I had to close the wound. By the time I think I was already having PFCL oil, and when we hemorrhage cleared, the thing cleared. 18 days later, I convinced him, and I did a third surgery where when I saw that there was a total detachment, the heavy oil which I used went subretinal. So I removed the subretinal oil. There was a macular hole. So I did a PFC, I removed the PVR, and I did. So I think I've operated a maximum number of expulsive hemorrhage, and trauma also several I have seen. And that's why I actually use the Flarengar's ring while doing regular any surgery with PK and temporary keratoprosthesis, which I saw many of them doing. So I use the Flarengar's ring. I don't know whether Zoran, do you use the Flarengar's ring?
Always, always.
Okay, so Dr. Mukherjee, you saw most of the vitreoretinal problems are along with the corneal problems.
We are getting outnumbered, rather.
No. But if you've seen, every eye has a corneal injury, whether it is a pellet injury or whether Dr. Matthew showed or Dr. Zoran showed. When injury does not know anatomy. And I always told that trauma books are written after the injury. And it's not written before the injury. So, as a cornea surgeon, what is your comments? Because you saw various suturing done, and then we finally do a PK, which is what we don't give up.
Excellent job done. I have one question to Zoran, that you used the scleral patch graft. Is it a preserved graft or a fresh one?
That was a utoplast, a pericardium that was freezed and packed. Pericardium, yes.
Okay. Not scleral.
What I would like to can I comment?
Yes, Purendra.
So actually, I've seen few cases. Matthew has also shown, Zoran has also shown. So I would like to, I would prefer to do two-stage surgery for the correction of visual acuity later on, and I would not do IUL at the same sitting. And that's what my personal feeling is as an anterior segment surgeon, because we have much better control when we do it as a secondary on a secondary stage. That's what my feeling is, but I think they have done a great job.
Purendra, these days the concept is whatever you do in a trauma case, do maximum as possible at one sitting, at one go. As Florini has shown, that maximum work should be done, maximum correction should be done at one go. You combine with anterior and posterior segment surgeons together and do the complete job.
Yes, our calculation and all other things with the IUL is challenging in first stage. That's why I was saying, because then you have a large amount of residual refractive errors in these cases. So we can, then they have to wear high power glasses and many other things are there. The lens position and other things are there, the chances of glaucoma, secondary glaucoma developing. So first we should make the eye quiet, but all these, there are two schools of thoughts. It's a personal thing. Yeah,
definitely.
But I learned the lesson from may I just say a comment? I learned the lesson from Matteo's father, Cesare Forlini, pole-to-pole surgery. And we discussed, I remember still very good, that the best choice is to do everything in first surgery, because after that you have a scarring that you cannot predict. And maybe postponing the surgery, waiting for the better results, you are losing the possibility that you had in the first situation to use the maximum, and then you try to get better, and then you lose the thing that was good. So the biggest enemy of good is better.
And also, I think Matthew to comment. And the other one is using AC maintainer. Even in a phakic eye, Dr. Cesare Forlini taught us to the whole world. Even though AC maintainer was used by Michael Blumenthal in small incision cataract surgery, but I think he adopted for even a phakic eye, even in a traumatized eye. He says the fluid goes from aqueous to the antechamber through the of the lens and back to the vitreous, which is I've also done. And particularly in endophthalmitis, it clears the anterior segment, it clears the intraocular lens and goes behind. Matthew, you have to comment on the combined surgery in one step. I think even I converted after being with Cesare. But anyhow, I'm happy. I worked with Cesare from late 80s. So we are together in the growth along with Dr. Jovanovic and even Zoran.
Yes. I just agree with Zoran Tomic. I already said before the same concept, like my father did. In the unique procedure can present many advantages. So if you are able to do it, and if you can, because sometimes you don't have availability of operating room or all the devices. But I agree with Zoran Tomic. Can I ask to Zoran one question?
Yes.
Zoran, the first case you showed us with the corneal transplantation, but you said that you removed only a small piece of cornea in the temporal sector. So you did a small corneal transplantation with the temporary keratoprosthesis. And then, of course, you put a small decentered corneal graft. Why? I mean, maybe you could do a big corneal graft, or maybe you prefer like that?
Yes, the good question, Matteo. That surgery was performed many years ago. So I decided to start. I didn't have a possibility. I had 7 and 7.5 millimeters trepansi by that time, and then I decided to cut out the part of the cornea that was destroyed. And then I thought to myself, because I couldn't support the cornea, the limbus was completely destroyed. So I was not sure that it is going to hold. And I thought myself, if the vision improved, I would make another PK for the vision. But it didn't go more than 360, so I left it as it was.
Okay.
I also agree that way.
Actually, the retina after your operation, the retina was good. So maybe visual acuity was bad for.
Yes, but the detachment stayed for 3 weeks and subretinal 4. So that was the complete story. Was 360, and it was not worth to repeat PK for 360.
But you did a great job on the retina. Really.
Thank you.
I think we've seen some wonderful results with primary surgery. And as an adnexal surgeon, as an oculoplastic surgeon, I would say that we do very much love that principle of primary surgery for eyelid surgery and lacrimal surgery particularly. So if you have lacrimal trauma and eyelid trauma, there is no opportunity like primary repair to give you the best results, when you can restore back the anatomy without any significant scarring and get back wonderful results. So I think that principle would apply many a times to intraocular surgery as well. Although there can be points of discussion there.
Okay, Grover, just a question to Dr. Grover.
Yeah.
So when you have a trauma like this, combined trauma, the lid and all this, and then the retinal trauma, what would be the best approach?
We would always have the intraocular part done first, and then the adnexa, then the eyelids come in.
Okay, I just wanted to ask you because you mentioned the primary surgery.
In the globe, we would prefer it to be done within the first few hours and at best within the first 24 hours. But for adnexa, I think 24, 48 hours, whenever you have the best elective way is quite all right.
Go to the next speaker. Can you go to the next speaker now?
Yes,
sir. Can you go to the next speaker?
Yes, sir. Yes, sir.
Our next speaker is Dr. Purinder Bhasin. As I told you in the beginning, that he is a very versatile surgeon. He is founder, director of the Ratan Jyoti Hospital at Gwalior. Earlier, he was secretary of Ocular Trauma Society of India. Now he is vice president. He owned a lot of awards from All India Ophthalmological Society and other international forums. He has done a lot of anterior segment surgeries. And as I told you, he is a very dynamic person in the world of ophthalmology in India. Thank you, Sir Purinder. I request Mehul to call him for presentation.
Can I have my slide, please? Thank you, sir, for the nice introduction. And I'm really obliged and for giving me this opportunity to speak in front of this international arena. I will be showing a few cases wherein how to manage the pediatric traumatic cataract cases. In our country, we see many cases with the closed globe injury and even the post-perforating injury. We see that when the capsule is ruptured, anterior capsule is ruptured and lens matter is in the anterior chamber. So how we manage it and how we salvage the eye, and at the same time, because these children, they don't really come in our country because they are from far and wide, from the periphery, from the poor background. So they really don't come for the frequent follow-ups. So how to avoid the posterior capsular opacification. So let me have my first presentation. I thank everybody. I have no financial disclosure. So this is the case wherein there is a ruptured anterior capsule and the lens matter is in the anterior chamber. The child is 12 years old. We avoid doing phaco, the hydrodissection. and the anterior capsule is cut with the micro scissor. All we do is we use micro incisions, and this is anterior capsule is then cut in a circular fashion. And then after removing the cortex from, because these are lens are very easily absorbed, so we can do it by IA, and we do a primary posterior capsular axis. The size should be around 4.5 to 5 millimeter. And then we place a 3-piece hydrophobic acrylic PCIOL in the sulcus. And as you can see, we are pushing the lens in the sulcus. And then we do push back the optic and through the primary posterior capsular axis and engage the optic in the posterior capsular axis. And this avoids, and everything is sutureless. So this is the case post-operatively at 1 year, uncorrected visual acuity, what the child has, a 6.6. And this is how we manage such cases. Another case, 12 years old, with a closed globe injury. There is a self-sealed scar present, which is between the cornea, iris, and anterior capsule of the lens and the lens. So with the help of micro scissor, we release all the adhesions and with this and check it with the iris repositor if there is any adhesion present. And by bimanual technique through the micro instruments, we remove all the tissue which is there and the scar tissue which is present, and enlarge the pupil in infratemporal quadrant, and a primary posterior capsular axis is started. We have to be very careful that not to leave the hold of the capsule when we are passing through the area of the capsule, the opacity, corneal opacity, and complete it under the viscoelastic. Then a 3-piece lens, as I said earlier, is placed in the sulcus, and a buttonholing or the optic capture in the posterior capsular axis is done. And we see if there is a presence of any vitreous in the anterior chamber, and a primary peripheral iridotomy is done. Everything is sutureless. So this gives us advantage that the patient, they don't have to come to us for suture removal, for the chances of posterior capsular opacification, which is there to avoid this. In this particular case, again, a 14 years old child, we did do a posterior capsular axis, but the lens was placed in the sulcus, and we had a thick membrane. After 1 year, the patient presented to us with a poor visual acuity. We are now going underneath the iris with the vitreous cutter, underneath the IOL with the vitreous cutter, and making a large, almost 5 millimeter size opening in the posterior capsule, which is opaque. And with the irrigation handpiece on, we are pushing the optic in this opening which we have created. So this maintains the visual axis clear. So what I say, this thing is that even in pediatric cases, even for the age of 12 to 14 to 15 years or so, we should do a primary posterior capsular axis in all these cases. That is what my message is. And then I will be another case. This is how, as Dr. Parenskun says, that we should plan a strategy in cases of ocular trauma. Road traffic accidents are very common and they can prove devastating, as in this particular case of 26 years old man who had met with a road traffic accident in the year 2015. That was on the eve of New Year. Everybody is in a hurry or rush to reach home. And this male had a triradiate tear right from limbus to limbus, and PR was accurate, but there was no reverse RAPD. CT scan, orbit, and brain was normal. So primarily, we did a surgical procedure of corneal tear repair with anterior vitrectomy, and whatever the iris was there, we had to, because there was iridodialysis, we had to remove. This is the post-op at 7 days, how the patient appears. Over the course of 10 months, the cornea and retinal status remained stable, but the patient developed refractory glaucoma. So after 10 months, we took the patient for AGV and aniridia IUL. My glaucoma surgeon is doing Ahmed glaucoma valve to control the glaucoma. So the pre-placed suture is passed 9 millimeter away. The priming of the valve is done, and then the tube of the valve is trimmed, and after fixation of the valve to the sclera by the fixation suture, the tube after priming is left under the conjunctiva. Then I take over and anaridia IUL. This is a large IUL which is around 9 to 9.5 millimeter size. A scleral tunnel is made, and a scleral fixation is done because there is no posterior capsule present in this case. And as we were discussing, I use AC maintainer. I avoid using viscoelastic in all such cases. And this lens is placed in a vertical meridian, and to avoid any further loss of stem cells in the region, in the limbus region, and we do it in a vertical meridian. So the 9-proline suture is passed. These are very delicate lenses because the haptic can break anytime. I had this problem once in the past, so I am very, very careful, and I tell everybody after the globe is secured, we fixate the lens to the sclera. The 9-proline suture is tied to the sclera in a tunnel, and then the Ahmed glaucoma valve tube will be pushed inside in the anterior chamber after reducing the size of the tip. And graft is, the corneal graft is placed over the tube because all these tubes, they get exposed by conjunctiva, gets eroded in the due course of time. So this will protect it and prevent further damage, the extrusion of the tube. So post-operatively, patient had 6/24 vision. This is the patient after 6 months of this surgery. There is a bleb present, and this is the case on the slit lamp. As you can see, the tube of AGB and anaridia IUL. And this is the region from where the patient is able to see. With the scleral contact lens, this patient had a good vision. Till now, he is maintaining good vision up to 6/9 part and 6/12. And timely, stepwise, appropriate intervention definitely can salvage the eye, and patient can be, so we can save the vision of the eye. Fortunately, he didn't develop any glaucomatous optic atrophy or the complications of the retina. So till now, he is maintaining 5 years down the line, and with the scleral contact lens, he is quite happy. Thank you. Thank you.
Thank you very much.
Management.
Pardon, any questions?
I have only one question.
Yes, sir.
Purinder, why did you use a corneal graft in this case?
Sir, actually, with the tube is a subconjunctival. So over the period of time, we have seen that the tube of the Ahmed glaucoma valve that gets eroded, that erodes the conjunctiva, overlying conjunctiva. So tube gets exposed. To avoid that,
normally we use a scleral patch graft over it. But why do we use the cornea?
Sir, scleral patch graft can also be used, but cornea is a transparent tissue, so it doesn't look. I mean, the visibility is better than as compared to the sclera. But it shines white when it is there in the subconjunctival region. That can also be used. But we have seen that that cornea, which is not, these corneas are in glycerin preserved cornea, which were.
Is that corneal tissue is not that strong as compared to the scleral tissue. Scleral tissue is stronger than corneal tissue, and most of the people use scleral patch graft over that tube.
Sir, nowadays people have started using this conjunctiva, the cornea also, because it is cosmetically better. Cosmetically, it is better. So that's why. And these are the not the.
President, I will not tolerate. You wasted one cornea.
No, sir, these are glycerin preserved, which are not used for the keratoplasties.
Okay.
These corneas are the same, those cornea. We are not using the optical cornea or graft, which are used for the grafting. So these are the glycerin preserved corneas.
Purin, thanks for some wonderful presentations. They had some valuable lessons for us.
Thank you.
May I add some comment? So I would like to underline also practical issue of IC maintainer showed here, also introduced by Cesare Forlini, Professor Natarajan. It's very practical in trauma cases. So endophthalmitis, also to perform sclera fixation to avoid pumping visco to the eye globe. So it was also a good presentation of this aspect.
Thank you, Dr.
Thank you.
Virendra,
Thank you very much.
May I ask something, Mehul?
Yeah.
One, till what age would you put sutures? Say, for example, a 1-year infant, would you still be without a suture? The second question was, in the presence of corneal opacities, how do you choose your lens power when you can't do a keratometry? And as it is in children, IOL power calculation can have its own difficulties and the undercorrections that you plan. So how do you reconcile, say, in a 4-year-old child or something, how would you calculate in the absence of a keratometry reading?
Very nice question, sir. Thank you. First is to tell what age we put a suture, we suture the wound. So I suture the wound of a child aged 2 years, up to 2 years, because there is a scleral rigidity is poor, so we suture them. After that, I see if there is a need to suture the wound, then we will put it in any case, whether the child is 10 years old even. Because if your tunnel is not proper, corneal wound is improper, and there is a leakage from there, so we will not take chance.
Yeah.
Second question, yes, sir. So second question is corneal keratometry. How to take the keratometry? So in these cases, what I do is I go for a real keratometry, and I use a pentacam for all these cases. In these cases, I use a central 3 millimeter zone, because that is the optical zone which we require. If we go beyond that, usually our other keratometers, they use 4.2 millimeter size of the cornea for the calculation of the cylindrical power or the keratometry. So if I'm using a pentacam for the central 2 or 3 millimeter zone, so that gives me close to normal keratometry, which I use in these cases. With a corneal scar.
Though in some cases,
and if the scar is large or scar is more, or it is involving the central area, then we use the keratometry of the other eye.
Right.
Yes, sir.
Actually, regarding posterior capsulotomy, we have done a randomized control trial and published in IJF. Even in adult, we advocate to do primary posterior capsulotomy in all trauma cases.
I think that is a good idea, because I do it.
I think I have shared the article. We have done the randomized control trial. It is in IGO.
So that saves the patient's follow-up visit, and that helps us. And there is no side effect or any complication of the retina, what I have come across in last. And this I am doing for last almost 10 years in my cases of trauma.
In very small children, when you do a PCC, along with it, do you do an anterior vitrectomy?
Little louder.
In very small children, when you do a PCC, do you do an anterior vitrectomy?
Yes, madam. Yes, yes. We do anterior vitrectomy. Even at the age of 7, 8 years or 10 years, if we do anterior vitrectomy, because these eyes, they post-operatively chances of inflammation are high, and there is a nidus for the development of PCO in such cases. So it's better to do anterior vitrectomy in such cases.
Do you see a recurrence, or sometimes do you see a opacification in spite of doing an anterior vitrectomy? If so, how do you manage?
So I showed one case. That was one case wherein we have done. The child was 14 years old, and after 1 year, the child came with the PCO. Although we did the posterior capsular axis in this patient, but we didn't do optic capture. So optic capture helps us and preventing the chances of PCO in such cases. Posterior optic capture is very useful.
I think IOL, what is your preference? IOL.
part. I use a foldable hydrophobic acrylic 3-piece IOL. And because that gives me the advantage that I'm going sutureless in these children. So that gives me that advantage. Otherwise, we can use PMMA lenses also, but that we have to put sutures in such cases, and induced cylinder is more. So that's why I use a 3-piece hydrophobic acrylic foldable lens.
So shall we conclude now?
Yeah, if there is no other questions, you can just give a vote of thanks.
Yeah.
And if anybody has to say anything, they are welcome, please.
Mukherjee, I think we can have a word of everybody have a few seconds starting from our international speakers. Robert Redak first for a few seconds, his comments, then Matthew, then Zoran, and Hudson.
Thank you very much for inviting me. It's really great honor. I have learned a lot. Really, the webinar covered the entire spectrum of trauma cases, from, let's say, strategic approach to really severe cases. All methodology we can use today, nowadays, with all technologies. So I really enjoyed, and thank you very much for invitation.
Thank you, Robert. Now, Zoran.
Thank you. It was a very nice company. I enjoyed it a lot and exchanged my experience with others. You learn something always with such meetings, and thank you for this invitation, Natarajan. All the best.
Welcome, welcome, Zoran.
Thank you. Welcome.
And Matthew.
Really, it was an honor and a privilege to be here. Really, it's like to stay among friends, because Dr. Natarajan, Dr. Redak, Dr. Tomic, we know each other for many years, and we met many times in all over the world. This is the first time that we meet in this virtual reality.
Without a hug.
We hope to meet again,
Yeah.
physically.
Yes, Hudson.
Thank you very much for asking me to participate. I was so honored to be with you. I have to tell you guys, I learned such complicated cases, and Pedro was watching with me here, my son, 9 years old.
Yes.
And I love all cases. And I want to compliment you, Natarajan, for organizing this, and count on us whenever you need our opinion and our participation.
Sure.
Thank you again for Revigo as well for your comments, and Zoran, Tomic, everybody's here on the panel, and very bravo, Matteo Follini.
Thank you.
Ravi,
I want to thank my colleagues for allowing me to participate as a panelist. I love ophthalmology and I love great food. So the next time I'm in Mumbai, I'm going to go on a food tour with Dr. Natarajan. We're going to try some Mumbai street food.
So I think Matthew enjoyed in Mumbai, and he's got a beautiful video. I hope you will send it to all of us. Again, he sent it to me every time I search for it. He's made a beautiful Bollywood movie where the Sheila Ki, what is that, Javani, and he made a beautiful song in the Operation Theatre of Aditya Jyot with all the surgeons. Beautiful video. I think he will send it, and we will enjoy it. I think that's what we do, and that's what we are missing. I think every week I was doing that all over the world. I'm missing it, but I'm happy. I mean, Kim was commenting that I don't travel, but I think first time 100 days in Mumbai, which is unlike me. So great.
Sure, you can share the video, of course, Natarajan.
And I think Gangadhar, probably it's too late for you, but I'm happy you are still there. Ganga.
Yeah, can I make a comment?
Yes, please.
No, yesterday morning, 6 o'clock in the morning, I was giving a talk to the APTO, that's the South American Trauma Ophthalmologic Society.
Yeah.
And I've since learned that American Society is forming an ophthalmic trauma society. We have the Asia Pacific Ophthalmic Trauma Society. And since we are the brightest stars of the galaxy from the European colleagues here in this webinar, I understand so far there's no European Society of Ophthalmic Trauma. So can I now encourage my speakers who are here, whom we have invited graciously, to come together, work with other ophthalmologists, and start forming a European Society of Ophthalmic Trauma? just an invitation. Thank you.
Yeah. And I think Robert Reddock's institute is a trauma institute for last 70 years. So I think from the
Yes.
World War times.
So now we can really plan next steps. If we have your support, and of course we will discuss with Matteo how to proceed, and we will come back to you soon.
Yeah, you have Matthew, we have Zoran, and many trauma surgeons.
Usually we meet every 2 years for the ISOT, International Society Ocular Trauma.
Yes, but we want a European society, and may I make an announcement ahead of time? September 4th and 5th, we are going to be doing our Asia Pacific Trauma webinar. I'm going to invite the South American team. I'm going to invite the American team. If by that time the European Society can form an ophthalmic trauma, at least a grassroots, we'll have 1 or 2 of your representatives to speak at the webinar. So inviting you for this first weekend of September. Of course, the president of our society is Dr. Natarajan.
Thank you.
So I think, Robert, we should take this idea. And I always wanted to do something for Cesare Forlini's name. And I know it's lots there. So I think we can have the European ophthalmic trauma. The reason there's a difference between ocular trauma and ophthalmic, I learned from Ganga there. And I remember when we were forming the Asia Pacific ocular trauma, that's how I named it. Because my orbit was small that time. So now I learned ophthalmic trauma includes eye and the adnexa. Otherwise, it's only eye. Ocular is only eye. So I think we can have we can give credit to Cesare Forlini's name for pole to pole, and I think we can have I know ISOT is there, where ISOT Klaus Hyman and from Israel Gera Treister formed it. But I think even though it started from Europe, it went off to America, and then it's still Ferenc is the leader. But I think, as Ganga said, we need regional things, and South America, I asked Hudson to do it. And America is already doing it as the American Society for Ophthalmic Trauma, ASOT. So European can be something linked to Cesare Forlini. And
Actually,
Robert
as Dr. Natarajan, as you know, of course, at every year at Retinal, we have the Forlini trauma course in Retinal.
High school trauma. I'm saying convert that into a European Ophthalmic Trauma Society and have some name of Cesare Forlini there in the form of prize, something we'll do. So I think, Robert, you should take the lead, and Hudson should take the lead for South America. And Ravi, already the homework is done. The American trauma is already there. And I think Sai has one slide so that Dr. Mukherjee will announce our plan as ocular trauma for the next month. We have one more interesting, newer idea which I thought we are a little ahead of Rupesh and Ganga on thinking. Yeah, this is the one. Dr. Mukherjee, sir, you can announce this idea on behalf of
Mehul will tell about this one.
Okay, Mehul, you announce.
Yeah, this is the competitive trauma video session. Anybody who is member or who is not member of Ocular Trauma Society of India can submit the video. And we intend to collect more than 100 videos, which will be evaluated. And the number of videos, depending upon, it will be for 1 or 2 or 3 sessions, which will be presented online. So everybody can enjoy that. And the toppers will be awarded with the prizes supported by Zivira Labs. And this is the plan for next month. The probable deadline will be 17th July. The probable next meeting date is the 17th July. And we try to evaluate all videos which we are receiving during that period.
If we can make categories, Dr. Behul, like ocular, adnexa, posterior segment.
No, that will be using for evaluation.
Details are already worked out. I think we are only announcing the competition, which we will do internally, which is already in the pipeline. Already the discussions are going on for last 1 month with the Zvira and Sai. OTSI program.
Next symposium will be on blunt
Congratulations.
And advocacy of trauma. Next symposium for the Silver Jubilee celebration will be on blunt trauma and its advocacy.
Okay.
And now we would like to thank everybody. Before that, for all international speakers, we request to be a member of Ocular Trauma Society of India will encourage us. And the form is available on this website. So we wish that all international speakers, as well as they can spread a word, they can be a member of Ocular Trauma Society of India. And I think Dr. Ganga already has started doing this. And we request all our speakers as well as their colleagues, they can spread a word, and we want to make some more international members for Ocular Trauma Society of India. And at the outset, we would like to thank all international speakers, all national speakers, all panelists for sparing their valuable time. Special thanks to Sai, who has worked continuously without having a single hiccups. He has provided great services, and thank you all. And we would like to see you again during our next webinar.
And I also take this opportunity to thank Zivira Labs, particularly Mr. Kumaran and Catherine, for doing great support and supporting our Ocular Trauma website. And thank Dr. Mukherjee, President, for giving me the opportunity to do this international webinar. And I'm happy, and I think I enjoyed every second of this. I know we planned for exactly 1.5 hours, then went to 2 hours, and finally it is almost 3 hours now. So thank you, Dr. Mukherjee, sir. So sorry for the, we all got engrossed in the discussion.
Celebration has started in a great way.
Yes, sir. Thank you. Thank you all. Thank you, Ravi. Thank you, Matthew.
Thank you, Sai.
Thank you all.
Thank you, sir.
Thank you.
Bye-bye. Thank you.
Thank you,
Good night,
Ganga.
Dr. Ganga.
Thank you very much. Thank you. Thank you.
Thank you, Ganga.
Thanks a lot. Thank you. Thank you, Dr. Kasturi. Thank you, Dr. Hudson, Zoran, all. Nice to meet you. Thank you. Thank you.
Yes, sir.
Very much.
All of
you,
you have a
Matthew.
nice day. I think you all have a day, and we are all having almost 10 p.m. in the